All right, so this week we are covering chapter 21, which is respiratory disorders in kids. Here are your learning objectives for this chapter. There are things that you're going to find familiar about this chapter. You have been exposed to a lot of other respiratory disorders with med-surg and other classes that you've been taking up until this point. We're going to talk about some pediatric differences with their anatomy, their physiology, and disorders that we see with pediatric patients, and just some of the differences that we see with some of those disorders that you may be familiar with, such as asthma. All right, things that we have to keep in mind when we're caring for our pediatric patients. Remember that their age impacts the respiratory status. Their size is a significant contributing factor to why kids have more challenges with respiratory disorders. They have decreased resistance, and seasonal variations are going to be a little bit different, and clinical manifestations are going to be a little bit different. So let's dig into those a little bit more here. So age, some of the factors that play into respiratory illness with our kiddos. Infants that are less than 6 months of age are obligate nose breathers. So they only know how to breathe through their nose. It's a reflex that they know how to breathe through their nose. You know, for you and I, if we got sick with a cold, we can open our mouths and kind of breathe funny for a few days. We snore more, right? We can compensate. But little guys under 6 months of age do not have that ability to compensate by breathing with their mouth. So we have to clear those airways. If they're sick and they have a cold and they're congested, then we have to make sure that that nose is clear so that they can breathe. Under 3 months of age, remember, they do not have an immune system established yet. They have some passive immunity from mom, so super susceptible to respiratory illness. Once they hit 3 to 6 months of age, we do start to see a significant increase in infections. They've lost some of that maternal antibody protection that they had for those first few months. If they are continuing to breastfeed, there is some continued passive immunity. Toddlers and preschoolers just get really sick all the time. Their immune system is learning how to fight off those viruses. It's building those antibodies, and it's a good thing. It's an important part of their immune system at that point, but it does mean that they get sick all the time with colds and coughs and respiratory illnesses. Once they hit about 5 to 6 years of age, kids don't get as sick with as many viruses. Their immune system is pretty effective. If they get a cold, they usually won't get as sick with it. They usually won't get a fever anymore. It's a lower illness like we see with adults when we get sick. We do see an increase in things like mycoplasma pneumonias and strep infections, like strep throat increases a bit more in that school age population. And we have that increased immunity as we get older into our adolescent years, when our immune system and our body is functioning more like an adult by that point. Our respiratory rate, remember, decreases as we get older. Remember, those infants have a fast respiratory rate that's irregular. It slows down as we hit to that 12 to 14-year-old age range. These are the most common pediatrician's visits that we see with toddlers. So again, most of them are respiratory related. Colds and coughs, croup, which is an upper respiratory infection, most of the time caused by viruses, but there's a few other things that can cause it, as we'll get into this lecture. Conjunctivitis, pink eye. A lot of times this is related to an upper respiratory infection. Kid gets a cold, all of those sinuses are connected to your lacrimal ducts and can cause conjunctivitis. So they're usually connected, not always, but they're a lot of times viral related. Sore throats, which are usually upper respiratory infection, kind of related to things like viruses. Earaches or ear infections, which are common, especially when kids get upper respiratory infections like a cold. Wheezing, when they get more of a lower airway issue, can be secondary to a cold. And fevers related to any of those illnesses, more common in younger kiddos like toddlers. And then vomiting and diarrhea, which honestly, this one, you know, most of the time it's related to an upper respiratory infection as well. A lot of the viruses like rhinovirus that can cause an upper respiratory infection also can cause diarrhea. It's something that we see with like COVID. It's one of the symptoms. Not every patient gets it, but it's definitely something that some patients will get with those viruses. Okay, so let's talk about airway size. They have a much smaller airway across the board. It is shorter in distance. So entry point, if we breathe in a pathogen, we breathe in that virus, we have those little hairs in our nose that'll catch them. But for kids, it is such a short distance from entry point to their lower airways that things can become more of an issue in those lower airways, more so than they do for us as adults. They're more likely to stay in our upper airways and just be kind of more of a nuisance than anything. But lower airways, more access down to those lower airways because of that shorter respiratory tract. Their eustachian tubes are flat. We talked about that last week, that a cold that sits in the sinuses can connect. It goes straight to those ear canals and cause ear infections in kiddos. Other anatomical differences are the size of the trachea. The trachea is much smaller. It's much more narrow. The diameter of that trachea is going to be much smaller for a peds patient. And just looking at the picture on your slide here, right, the kid's trachea, down here, there we go, is much smaller, right? My pinpoint here is taking up the whole size of their airway here, but if I move it to my adult, it's not taking up that whole airway. So when we get a cold, we get any sort of inflammation that can happen with a cold, it occludes the airway. And for kids, they just don't have as large of an airway to compensate. Their trachea is the size of their pinky finger until about 5 years of age for little guys. So think about an infant. Think about how tiny their hands are. Think about how tiny that finger is. That's the size of their trachea. And for me, I have a pretty small hand, so my finger is fairly small. This would be a small airway to begin with, but an infant, a 1-year-old, a 2-year-old, their trachea is the size of their pinky finger, which is even smaller. So significant differences there in airway size. Other things to think about is their muscle mass. Their diaphragm is stronger, or is weaker than we see with adults. It is thinner. It's not as strong. All of our other muscles, right, our sternocleidomastoid muscles, our shoulder muscles, any of our other intercostal muscles are going to be weaker for infants and young kids. And they get stronger as we get older, but their ability to compensate with those accessory muscles is not as strong as it is for us as adults. They have their main diaphragm as their breathing muscle, but they don't have a lot of those extra accessory muscles to help them compensate. They do have more adenoid tissue. We've talked about that in class, right? More adenoid tissue, more lymphoid tissue, and that can also contribute to things like airway obstructions. Their epiglottis is a little bit more floppy, so it could occlude their airway a little bit more easily as well. So size and structure of the airways is a contributing factor for their ability to deal with illnesses, especially respiratory compromise. All right, so this just kind of represents that airway edema that I was talking about. And so you've got here on this side is your adult with no inflammation and your infant with no inflammation, about what size that you see with their airways. Now here is just a 1 millimeter of diameter to breathe from when we have airway inflammation that can happen, like a cold, anything like that. You get this cold that contributes to airway inflammation and it affects that airway. And this is a 50% reduction in their airway size with that inflammation. The same amount of inflammation in an adult is only about a 20% reduction in airway size. So we still have a very large airway that we can breathe through versus this infant that's going to have a more easily occluded airway. Remember, that trachea is about the size of that pinky finger until about 5 years of age. Other differences that we see with kiddos, so bifurcation of the lungs, where the lungs split off to right, left main bronchus. It's higher up for kids. So again, easy entry in the nares, shorter distance, things can go down into those lower airways a little bit more easily. So for young kids, it's about the T3 level, and you can see in the picture here, right here, right here. And then it starts getting a little bit lower down in the chest, right? And for us as adults, it's much lower. So it's about T3 for infants and young kids, which is, kind of about right here. For us as adults, it's about T6, which is much lower down on our chest, kind of like the middle of the chest. So things don't get down there as easily, get down into our lower airways as easily. It's also a steeper angle for younger kids, so that right main stem bronchus is a little bit straighter, like kind of straight down. for us as adults is a little bit more angled. So things more likely to go straight down into that right mainstem bronchus than the left, but it's just a straight shot, more of a straight shot down into the lungs than we see with adults. Because of that shorter structure. And take a look at the diaphragm in this picture as well, right? See here with the diaphragm with this infant, see how thin it is compared to your adult diaphragm. And even the child, the young child here is more developed over to the adult that is much more, much bigger, much more significant in size, allows us to compensate more easily when we have trouble breathing, like kids get. Other things that contribute to decreased resistance, remember their immune system is still being built up. If they have allergies or asthma, that can contribute to decreased resistance, ability to compensate with respiratory illness. Cardiac abnormalities or defects, cystic fibrosis, which is a respiratory disorder that we'll talk about today, and kids in daycare, mainly because they just get so much exposure that they can get sick over and over again, and it can be hard for them to kind of come back from that. Secondhand smoke impacts the lungs, especially for kids that already have something like asthma or allergies or a cardiac abnormality. It's going to put more work strain on their lungs. And I think for us as adults, we can more easily get out of those situations. You know, if we're around somebody that's smoking, we don't have to be around them. We have independent choice of being able to step away. A lot of kids that are exposed to secondhand smoke, it's usually because the parents are smoking and they don't have a choice, right? They can't just leave the house because the parents are smoking. So we do talk about ways to help limit exposure to kids, you know, such as things like not smoking in the house, not smoking in the car if the child's with them, you know, wearing something like a smoker's jacket that they can wear when they go outside, and that gets taken off and left at the front door so that it's not bringing in that smoke. So decreasing exposure for the kiddo. And then risk factors with malnutrition and anemia. They're going to have problems with compensating if they have respiratory disorders and delivering oxygen to the tissues. Seasonal variations are also another big factor that play into what we see with respiratory diseases. Now, this is being recorded in the fall of 2021 after we've had almost 2 years of impact from COVID. This has significantly changed the face of respiratory illness in kids. What would be a normal typical respiratory season last year did not happen because of COVID and because everybody was socially distant. People were wearing face masks and hand washing. Kids didn't get sick. We basically didn't see a flu season. There were just a couple pediatric flu deaths, which is unheard of in a normal flu season. Kids die from the flu, unfortunately. This fall, however, our seasonal variations has exploded much earlier than what we typically see. So most of the time, our seasonal variations are about December through May in Colorado, in the United States, right? In Colorado, that's what we see, about May through December. And December through May. So the increased infections, you know, the normal colds and coughs and those kind of things spread during that time of year. We see mycoplasma infections, like mycoplasma pneumonia is a little bit higher incidence in the early fall, early winter time when kids start school and they're kind of sharing germs again. Asthmatic bronchitis is a little bit more common in the winter time in Colorado, just because it's that cold air that can trigger it. They get a cold, they get more sick with it. We also see it kind of a little bit more in the springtime. And sometimes we see it when we have, you know, wild weather fluctuations in Colorado, like spring and fall, when we have a nice, lovely 70, 80 degree day, and then it's like 20 degrees the next day. That can also trigger some of those asthmatic events. And then RSV is a contributing factor to respiratory disease in children. It's one of the most significant respiratory viruses besides the flu and COVID that we see with kiddos. And I've got a typical map here, and this is a few years old, but this is what we typically see every year, is that here, December, spikes up and then it drops pretty rapidly before the summertime. And we see that with a lot of respiratory viruses. COVID has not behaved that way, and some of that has to do with just exposure. The other map that I've got here The bar graph that I've got over here is Florida. Florida's weather patterns, because they are warm, they're more humid, they have just a different season than we do in Colorado. Their RSV looks very different. And you can see here that their spikes kind of August is when this starts to go up, and then it stays high for a lot of the respiratory season, and it'll drop again in the summertime. But theirs stays high kind of consistently. And the belief behind that is that it's related to the humidity and the warm weather patterns that we see in Florida. One of the other things to keep in mind with this is COVID. So it's October 2021, and these are data points for this time right now. This first one on this side here is about 3 months ago, so this was taken in the summer months, and you can see the dates on here. This was May into June, July. This one over here is our October dates, into October dates. COVID has spiked significantly since the summer in Colorado, and there's a lot of reasons why we're seeing the spike in kids. We were only seeing like a couple cases being admitted to the hospital on any given day for COVID. Kids were socially isolated. They weren't going to school together. They weren't sharing germs in the typical sense. Occasionally they were getting exposed because the adult in the family was bringing it home, but they weren't sharing all of those germs in the classrooms like we have been seeing with our peds patients. But that's changed this year, right? School started back at the end of August, beginning of September, and now kids are sharing classrooms and spaces and sports programs, and they're doing their normal activities again. And so that has led to an increase in our infection rates. So while this bar graph here, or this line graph here on this one side looks about the same height, look at the numbers, point out the numbers here. This one only goes up to 60 on the left hand side there. This one goes up to 250. So the line has shifted because we're seeing so many cases of it now that the line has just shifted much higher. So this is on average 150 positives a day that we're seeing with this over the last 8 weeks. Now, the other thing that I'll point out too are normal respiratory viruses that we don't normally see spike until about December for flu season, respiratory season in the state of Colorado has also shifted. Again, look at the numbers here. On the left-hand side, it only goes up to 60. On this side here, it goes up to 150. So it's shifted. The line has shifted much higher, and you can see that it's spiking. This one is our RSV or rhinovirus here. We've also got the RSV rates have increased. Pretty much everything has shifted and gone much higher. Now, there are a couple that have dropped a little bit. Parainfluenza has dropped a little bit in general, but everything has spiked. The hospital basically is full right now at a much earlier time than we typically see. But normal seasonal variations hold true in other years, and so we hope again maybe next respiratory season will look like that, but we don't know when this current respiratory trend is going to drop off. So keep in mind that the clinical manifestations for children are going to be different than they are for adults. We don't see the same risk factors. So I want you to watch the video that's linked in here. Go ahead and pause this video and go watch it. It's a video that goes over some basic respiratory assessment with kids. And I want you to think about that as you're watching it. It's just like the differences that we see with pediatric patients versus adults. Now, what does respiratory distress look like for a pediatric patient? It looks different. Kids can compensate less easily, right? Remember, the lack of muscles, lack of that diaphragm, they just can't compensate as easily. So an infant will maintain, and then crash, and they can crash much more rapidly than we see in adults because we don't have as much ability to compensate. So hopefully you've paused, you went and watched that video, and I want you to think about those signs and symptoms of respiratory distress in a pediatric patient. So what are they? I want you to think about some significant ones, like increased vital signs, right? So increased respiratory rate, increased heart rate. Fix that. Increased respiratory rate, increased heart rate, right? We're going to compensate. Our body's going to breathe faster. That's the first thing that usually starts to happen. We're going to breathe faster to try to circulate that oxygen. And then our heart rate's going to go up to try to compensate for that as well. So tachypnea and tachycardia, we'll see, right? What other signs of respiratory distress might we see? Things like retractions. So those could be intercostal retractions or suprasternal or supraclavicular retractions. So retractions. And in the video, they talk about something called grunting. Grunting is a very severe sign of respiratory distress. When a child is grunting, a child is trying to create positive air pressure because their airways are not staying open. So think about the kiddo with bronchiolitis. Lots of secretions in their airways and they get stuck closed, right? So if we have a patient that's grunting and they're doing something like this, and they're kind of making that grunting sound and usually end expiratory, they're trying to PEEP themselves. They're trying to cause some positive end expiratory pressure by doing this grunting sound. So I'm going to star this one and put grunting. Grunting. Terrible writing on the screen. Grunting is something that I want you to think about. That's a pretty severe sign of respiratory distress. If you have a child that's grunting in your care, you better be doing some significant interventions to reverse that respiratory workload. What are some other things we might see, right? We talked about heart rate and respiratory rate and retractions, but we might also see some other things that are related to that, like decreased PO, decreased feeding, which can contribute to fluid and electrolyte imbalances, which can make respiratory issues worse. When we're struggling hard to breathe, we're going to have trouble eating. And that can contribute to things like aspirations. If they're just breathing that hard and they're trying to feed at the same time, they can breathe at the same time they're eating and they can aspirate. So decreased PO. What else? Talked about retractions and grunting. Things like head bobbing or something that we sometimes see where a patient is breathing and they're doing this. They're trying to use some of those accessory muscles, so they're head bobbing, kind of like those bobblehead dolls. Head bobbing. Head bobbing. We can also see things like nasal flaring, where those nares are going out. Nasal flare. Pen's not working great today. Nasal flaring. What else? Color changes, right? Color change. Come on, pen. Color change, right? And that could be pallor or cyanosis or rubor. Remember in our darker tone patients that we're assessing things like our mucous membranes, pallor, especially in the conjunctiva, looking in those eyes. So color changes, decreased SpO2. SpO2. Decreased oxygen. Now, this is a lot of times a late sign of illness in kids. Kids can maintain by increasing that respiratory rate, increasing their heart rate until they no longer can. So you may not see a drop in their SpO2 initially. They may have all of the other symptoms. They may be tachypnic and tachycardic and pale and not looking great, but still have an okay SpO2. But absolutely, if we're seeing a low SpO2, that may be a problem. Think about your lung sounds, your lung auscultation. Abnormals could be things like crackles or wheezes or stridor or rhonchi, diminished lung sounds if they don't have much airway going on. So listening to the lung sounds and listening for those abnormals that I've got down here, right? And then things that go along with illness, right? We typically see a cough or congestion or sometimes things like a fever. Remember, those fevers are more common in the younger kiddos. Even with a cold, they can get a high fever with it. And it doesn't necessarily mean that they're any sicker than other kids. It just means that that immune system is working a little bit differently than it does for an older child. Good. So think about those signs and symptoms of respiratory distress in kids and how they're a little different, right? We're less likely to see nasal flaring in an adult. We're less likely to see grunting in an adult, but those are things that we can see with our peds patients more easily. Now, these are the red flag kind of respiratory rates that, when we're looking at a patient, kind of a quick reference to say, okay, this is too high. Remember, kids breathe much faster when they're younger, and it slows down as we get older. So generally 2 months and under 60, up to that 12-year-old age range, we say more than 20 is too fast. And then respiratory concerns. I've got descriptors of the different types of airway sounds, and this isn't all of them, but just a few of the airway sounds that you may commonly see heard. On an exam, I don't have sound, so you won't get an audible that's like, is this wheezing? Is this stridor? Not to say that won't happen on a future exam. Right now, the HESI doesn't, or the NCLEX doesn't have sound on it, but you never know. You need to know descriptors. So if I'm telling you wheezing, you have a patient that comes in and you listen to a high-pitched whistling sound that's happening during breathing, then that would be a wheeze, right? So being able to look at a descriptor and know when those are present. Wheezes can happen with a lot of different disorders. It's associated with things like asthma or anaphylaxis, but it can also happen with bronchiolitis. And as you're learning lung sounds, practice, get in there and practice, listen to computer audibles. It's helpful to kind of get familiar with kind of what they sound like, because they're pretty good nowadays to be able to mimic and record what real lung sounds sound like. But when you get out and practice and you're listening to patients' lung sounds, go in and listen first. Don't let your preceptor tell you what they're hearing. Use those skills that you've learned, use the process of listening to the lungs, and listen to it and think about what you have in your head of, oh, I think this is wheezes or whatnot. Have your preceptor listen, and then see if you're right. Tell your preceptor, I think I heard wheezes in the right lower lobe, and see if you get it right. That really helps build up that confidence to be able to listen to those lung sounds, because it is a skill that takes a little bit of time. Okay, continued with this with different signs. Remember I mentioned that cyanosis is a late sign, that you may not see cyanosis initially, even though they're exhibiting signs of respiratory distress. And then level of consciousness is often an early indicator of hypoxia. So if your patient is sleepy and just not as responsive, remember I've mentioned the term age appropriate. If you're starting an IV on them and they're not fighting you and you've got a 2-year-old, that's not age appropriate. If they're lethargic, they may be not getting enough oxygen. All right, nursing intervention. So if we have a kiddo that has respiratory distress, we need to intervene. We need to do something to correct whatever this problem is that we're having, right? And related to a lot of things like colds, it is suction, humidification. The things that we think about at home would be home management for this kiddo. Now, young kids, infants especially, cannot clear their own airways. They don't know how to blow their nose yet. You and I can do that usually if we've got a stuffy nose. Sometimes it works, sometimes it doesn't, right? But infants and little kids, like toddlers, don't usually have that ability to clear their own airways. So we have to help them. And we have a couple tools for that. In the hospital setting, we can use wall suction. It's great, it works fast. There's multiple different things that we can use for suctioning our kiddos. At home, parents need to be able to do this as well. So we have those bulb suctions. They're great. They do work. My thing with them is that they get really gross at times, right? If you're using it and you're not cleaning it out on the inside's going to be black. If you ever cut one of those open, they're pretty black. There's also things like a nose Frida, and that's what's on the slide here. This is a nose Frida. It's going to sound gross, but basically this takes one end, this blue tip here, that goes into the little baby's nose. The other end with the little mouthpiece on it goes into the parent's mouth. And this can be used to suction boogers. Before you panic about it, there's a little filter that's in between here that doesn't allow those boogers that get sucked into the little blue tube to go up the tube into the parent's mouth. This honestly can be as effective as wall suction. With saline, right? We want to make sure that those secretions have been thinned out so that they can get suctioned out a little bit more easily. So I always recommend several drops of saline will help clear those airways. One of the things that for kids that are super congested, I like to do this especially at bedtime. If I'm in the hospital and I'm doing suctioning before bed, I take that wall suction and I use the nasal aspirator, which just goes in the tip of the kid's nose, just like this one does, the nose Frida does. Get that in there, and then if you suction out at the same time you're squeezing saline in the other side, it gives you a nice saline flush, and it will clear the airways pretty thoroughly and allow them to sleep a little bit more easily. You want to make sure you have that suction on, though. You're not just drowning them with drops of saline into their nose. So saline to help thin it up, suction it back out. Whether that's at home or in the hospital setting, that's an important part of management. Sitting kids up. If we're upright, we can breathe more easily. If we're laying back, all of that junk sits in there and causes more airway occlusion. So sit them up. Put them in a baby swing or a baby seat. An infant seat of some sort is really helpful. In the hospital, we have beds that crank up. We have a bed that can elevate. The head of the bed can elevate. In the home setting, parents don't have that ability, right? The standard crib does not have a crank on it. It just has a mattress pad. Nothing in the crib. Remember, I've mentioned this a couple times. Do not put anything in the crib. So you don't want to put them on a pillow. You don't want to elevate them on a pillow. The best way to elevate the bed at home is to take the mattress and lift it up and put a pillow underneath the mattress. So I tell parents to use a couch cushion because they're nice and firm and they won't like sink down like a bed pillow will. So put that couch pillow underneath the mattress, and now that the mattress is elevated, and then baby can sleep in this elevated position. However, if you're not helping baby not slide, baby will just like, and they'll just slide down that elevated surface, right? So taking a little towel roll and rolling it up into a tube, just rolling it up so that it's now in the shape of a tube, and then putting it in a U shape underneath the little baby's butt. So they're like sitting here and they've got it like underneath their little butt. That will keep them from sliding down as easily. So that's my recommended on that, to keep them upright. Or they can go into an infant seat or swing or something to keep them in that elevated position. Humidification is really important, especially in Colorado with our dry environment here. We need humidifiers in the room. That helps keep those airway secretions thinner so that they can get cleared more easily. Promoting rest and comfort. Comfort from parents, comfort from kiddos. Sometimes it's wherever they're comfortable. Some kids want to be close to the parent when they're sick. A lot of kids want to be close to the parent when they're sick. So we're promoting that rest and comfort, and that kind of goes along with fever management. You know how you feel if you're sick, right? You feel crappy. Even if you don't have a fever, Motrin and Tylenol can help with just the general body aches, with a fever or with a headache, with pain of any sort, just like feeling crummy because you're sick. So give them some Motrin or Tylenol, and that may help as well with sleeping. Infection control is really important. Good hand washing in the household. Respiratory protection if it's a respiratory virus that can be breathed in. Parents oftentimes get the same cold or illness from their child because the kid's sick and they want to be comforted by the parent. But if the parent is too sick, then they're not there for their child. So making sure that they stay healthy as well is important. Promoting hydration and nutrition. We've touched on this a little bit in class so far, but hydration especially for kids is really, really important. If they're dehydrated, their work of breathing is going to be harder. They're not going to be able to oxygenate it as easily. That fever could be worse. So it can impact a lot of their body systems. The fever being worse uses more fluid. So making sure that they're hydrated, whether that's drinking orally or IV, depending on how severe their respiratory status is. Nutrition is also something to keep in mind, right? Our body cannot fight off illness as easily if we're sick. But if the kid's got a common cold, they've got RSV or rhinovirus, and they're not wanting to eat for the first couple days, it's not the end of the world. Now, it's prolonged malnutrition, then that absolutely would be something we need to address. But if the kid, the first couple days of illness is drinking okay, but not eating, it's not the end of the world for the kiddo. Warning signs, those signs of respiratory distress that we just talked about, grunting, retractions, tachypnea, those are all things that we're watching for in the healthcare setting, as well as educating parents about. I tell parents how to count a respiratory rate, what are retractions, and what is the difference between mild to severe retractions, because mild retractions may be totally fine for the kid at home when their respiratory is increased. But severe retractions is not okay at home, right? They need to be seen. So what are warning signs of respiratory distress? When to return to a healthcare provider and make sure that that kiddo is staying safe and is getting the care that they need. And other family support and teaching things would be things like suctioning. I make parents demonstrate back to me before they leave, especially in the ER setting. Can you suction effectively? Because I have a lot of families that'll come in and they're like, well, my kid hates it. I hate suctioning them because my kid hates it. Yeah, nobody likes being suctioned. Nobody likes a tube being stuck up their nose and being suctioned. So yeah, they hate it. You are the parent, you have to do it because they can go downhill if they can't breathe. And it is a contributing factor to kids that end up needing to be hospitalized, is them not being suctioned, and that work of breathing goes on for a prolonged amount of time, and they just tire out and their oxygen starts to drop and they end up in the hospital. So those are things that we need to think about. And this is kind of across the board with most different types of respiratory disease processes. So we're going to start with infections of the upper respiratory tract first. Nasopharyngitis, pharyngitis, tonsillitis. I'm not talking about mono today. I'm not going to talk about flu today. Those are ones that mono, not too significant, but definitely something we see more in like teen population. Influenza. Most healthcare providers, especially students, are familiar with influenza. You've talked about it with peds patients, and it's no different than any other viral illness other than the severity. And then ear infections we're going to touch on as well. Okay, so the first upper respiratory infection we're going to talk about is viral nasopharyngitis, right? Nasopharyngitis, throat, mouth. This is the common cold. This is the most common thing that we see with kids across the board. They're just going to get sick with so many of these over the course of their lifespan, especially when they're younger. And there's lots and lots and lots of viruses that cause them. I've got a few on the slide here: RSV, rhinovirus, adenovirus, influenza, parainfluenza, coronavirus. Coronavirus has not been, it was not a new thing, right? It's been around for a long time. Typically a very mild illness though. So the form of COVID that we have now is significantly different than what we used to see. Fever is something that we see with colds in younger kids, typically below 3 to 5 years of age. They may get a fever with their cold. Again, it doesn't necessarily mean that they're sicker than an adult. It just means that their immune system is learning how to fight off the infection. Treatment is primarily home management. The suction, the humidification, the sitting them up, the comfort measures, Motrin, Tylenol, all of those things. Typically, if they end up getting hospitalized for something like RSV or rhinovirus, it's because of respiratory distress and oxygen perfusion, that they're just not getting their oxygen needs met. Acute infectious pharyngitis and tonsillitis, so inflammation of the tonsils. Viral and bacterial pathogens cause this. Strep throat is a very common one in our school age group. Viral infections are more common in the younger age kiddos, but a viral illness can cause a pharyngitis or tonsillitis in any patient. They have trouble swallowing sometimes. It really hurts to swallow. So pain, enlarged tonsils, enlarged or a sore throat, fever sometimes. More common to see fever with the younger kiddos and something like strep throat. So treatment is primarily symptomatic support. If it's viral infection, it's a cold, it's going to be symptomatic support. So suctioning, humidification, Motrin, Tylenol can help with all of the symptoms. If it is a bacterial infection like strep throat, then they do need antibiotics. And we would make sure that we culture it first and that we're not just automatically prescribing antibiotics to somebody that has a sore throat, because most of the time it's a viral infection. But if it is bacterial, it's strep, we give antibiotics and treat it. Now, there is a risk for strep throat, especially untreated strep throat or prolonged illness with it, that can lead to chronic issues like glomerulonephritis or rheumatic fever, which can lead to more complications, as we'll talk about later this quarter, in GI and as well as cardiac. Tonsil and adenoid ectomies are one of the most common surgeries that we do with kids, and right around kind of early school age is the most common age that we see this with, because kids get strep infections more frequently at that point. And it's mainly only reserved for kids that are getting like 4, 5, 6 strep infections in a year. My daughter had untractable, irretractable strep throat. Basically what ended up happening when she was about 3 is that she would get strep, we'd do 2 weeks of antibiotics, she'd be good for about a week, and then we'd have symptoms again. And a lot of times in younger kids with strep throat, vomiting is one of the symptoms with it. So we just did this every month, basically every month for about 6 months before I finally was like, okay, we're done. She's not, clearly the antibiotics are not working. We've done strong antibiotics, we've done everything. And she kept getting these infections, so we ended up having a tonsil and adenoidectomy done. Thousands and thousands of kids have this done every year. This is a really common surgery, and I've taken care of inpatient, I've taken care of outpatient. I have seen every complication that there is to see with a kid that's getting a tonsil and adenoidectomy. The tonsils are usually taken out if the kid's getting strep throat. The adenoids are taken out if the kid's getting ear infections. So it's not uncommon to see both of them done at the same time. If the kid's just having problems with the tonsils, then it's just a tonsillectomy though. My daughter she had a couple ear infections as a kid, as most kids do, but she didn't have recurrent ear infections, like the strep infection, so she didn't get an adenoidectomy, just a tonsillectomy. So before patient goes in for the surgery, we want to make sure that we're assessing for any active infection, especially an upper respiratory infection. Upper respiratory infection, we cause inflammation because of surgery, can make things really bad. We want to make sure that we're assessing for loose teeth. Remember, in our kids, just like our elder adult population, they may have loose teeth that are falling out. We don't want to knock that out or have them swallow it or something while we're doing surgery. Bleeding and clotting studies are sometimes done ahead of time. This is a very vascular area of the body. It bleeds really easily. So we may or may not do clotting studies, like a PTT, to check how long it's taking them to bleed. Not always the case. We want to make sure that we've prepared the kiddo, right? That age-appropriate preparation that I've talked about, that we've talked about the surgery. We're not telling them necessarily how and what's being done, right? I'm not going to tell the younger kiddo, the toddler, the preschooler, that we're going in with a scalpel and cutting off their throat. No, way too graphic with the kid at that age. An adolescent may be able to understand that, and they may ask, they may be more detail about it. But the school age kiddo, you're going to be very basic still. You know, that we're going to take out that portion of the body that's causing you an infection without going into things like a scalpel or cutting it off. So prepare them age appropriate prep for the procedure. Now, one of the things that a lot of children's hospitals have available is working with a child life therapist, and the child life therapist does a lot of prep for kids. So it's not always just us as nurses that are doing it. Sometimes it's a child life therapist. And if you're not familiar what a child life therapist is, they have usually master's degrees or above in child development. And so they really understand the developmental level of our patients, and they can come in and give that education. So one of the things that Children's Hospital here offers is, especially for outpatient procedures, you can make an appointment with a child life therapist ahead of time to go in, meet them, see the process of having the surgery done. So we had this done for Aria for her tonsillectomy. And for kids that are preschool age, you want to do it as close to the time as possible. So we came in on Thursday night for Friday morning surgery. And that was as close as possible for early Friday morning surgery time. If you have a kid that's in the hospital and you're going to be doing surgery prep with them, do it as close to that surgery time as possible for them. If it's 30 minutes beforehand, that's best case scenario, just because of that short attention span and ability to remember things. So we went in on Thursday night for her, and I've mentioned in class that she's kind of a shy kid, so she doesn't like talking to strangers. She's visited me numerous times at the hospital, knows that I work there, but talking to somebody new like the child life therapist, she was like, I don't want to talk to you. So we did a tour. We walked through the OR. We did all the prep, and got her ready for that process beforehand. So when we came in the next morning, when we came in for the surgery the next morning, she was ready to go. She understood what she needed to do. She, went up to the play table right away. She got dressed right away. And she just knew the process. So a lot less stress. When we first went in on Thursday night, she was like clinging to me, clutching to me. But by Friday morning, was much more comfortable in that situation because she'd seen it and was more familiar with it. So we want to prepare kids for that. We also want to talk about what the post-op process is going to be. For kids that are old enough, talk about the sore throat. It's going to hurt. It really sucks. So you got to drink. And I encourage parents to do things like getting a special sippy cup or a special straw cup, something along those lines. Even though I know I've got down here no straws, this is kind of one of those like, an older kid, we would encourage not to use a straw, like just using a regular cup to drink from. But the younger kid, if they're used to drinking out of a sippy cup, it's a low risk. Let them drink out of a sippy cup usually. So talk to them about that and the really important reasons why they need to drink afterwards. And then your post-op care with this patient, warm gargles, and we recommend saltwater goggles, school age and up. A younger kid will just swallow it, so it's not helpful for the younger kids. Ice, there are these like fancy ice ring collars that patients can wear. Sometimes we'll discharge a patient home with them that kind of go around. It's kind of like those C-spine collars, if you've ever seen one of those that like strap around the neck. Kids never like wearing them, right? I don't think it would be comfortable wearing ice around the neck, but ice reduces inflammation, so it can be helpful for that reason. Most of the time, if they're not going to wear that, things like ice chips or a popsicle or something cold, also swallowing those cold substances also really helps with reducing inflammation. So ice chips would be a great choice as well if they want to do that. Antibiotics as ordered. This used to be standard that every physician ordered antibiotics post-operatively, like everybody got them prophylactically. That's not the case anymore. We're trying to reduce rates of antibiotic use in kiddos, so it's only prescribed if needed. So if they're having complications, they have a fever after surgery, would be a reason maybe that we're going to give antibiotics. We want to monitor for bleeding. This is a very vascular area of the body, so the highest risk is going to be the first 24 hours and then 5 to 10 days afterwards. Little kids that have this done often will stay one night in the hospital because they're a little bit higher risk for bleeding and not being able to speak up about it. Older kiddos, it's an outpatient kind of procedure. And things that we see, especially in the little kids, if they're bleeding, maybe things like frequent swallowing where they're just like, and they're just like, you can see them frequently swallowing. Sometimes it'll be a kid that's telling us that their mouth tastes really metallic or it tastes different. If they've fallen asleep, is it like excessive drool that's coming out? It's okay to see a little bit of pink tinged. That's normal, but if it's like a lot, we want to speak up about it. And they just are really high risk that first day, and then about a week later, when the scab that forms over that incision falls off, it can bleed a little bit more at that point as well. So the first day and then about a week later, that increased risk of bleeding. Vomiting is also something we would look for in a kiddo that we're looking for that, and we want to avoid anything red. I've got on the slide here, avoid red stuff. And the main reason for that is if they vomit, we can't tell if it's like the red jello that they ate or is there blood tinged in there. So we want to avoid red stuff. Orange is okay, like orange popsicles are okay, but not red stuff. Soft diet for a minimum of 2 weeks. So soft diet, whatever they want to eat for the 2-week period. My dad watched my kiddo for me when Aria had this done. I came back to work about 5 days after she had it done, and my dad was watching her. And good day. She was great when I left in the morning, happy, chirpy, drinking okay. I come back and she was okay, went to bed, but the next morning she was awful. She wouldn't eat for me, she wouldn't drink for me. She was really fussy and just irritable, and I was doing medications around the clock and she just wasn't drinking for me. So called my dad and I was like, hey, just curious, what did she eat yesterday? Go through the process. He's like, oh, this, that, Chex Mix. Oh man, I was so upset when he said Chex Mix. Definitely does not fall into that soft food category, right? And because she was right about that 5-day window, I think it just abraded the inside of her poor little throat and took off those scabs. And she was just in so much pain that the Motrin and Tylenol wasn't working for her anymore. And so this pain control that we talk about, we want kids to get pain control, and it's usually around the clock for the first few days. Tylenol around the clock, every 6 hours or so is what we recommend. Motrin can be used, but sparingly. It can increase risk of bleeding, so we try not to use it too often. Most of the time, if the Tylenol's not working enough, we say try a dose of Motrin while they're awake to see if that helps. And that was definitely the case with my kiddo. She did not, Tylenol really didn't do much for her, so Motrin was needed, and she would eat and drink for a couple hours after Motrin, and then she'd have like a period of 1 to 2 hours while it had kind of worn off while we were waiting to be able to redose that she wouldn't eat or drink. But nothing was working this day. So day about 6, nothing was working. Motrin, Tylenol, nothing. She was just not wanting to eat or drink. She had not peed all morning and had those like dry, sunken eyes. Her lips were cracked. She was just kind of lethargic and puny looking. So by the afternoon, I ended up calling the nurse line. This is what we tell parents to do, right? Return precautions. If they're not drinking, if they're not peeing, return precautions, right? So I called the nurse line for the ENT clinic and I asked for stronger pain control because I felt like she just needed, you know, a single dose of like Percocet or something to get her over this pain hump so that we could get her drinking. And they wouldn't prescribe it. We really try to limit narcotic use in our pediatric patients. We used to prescribe them all the time for kids with tonsillectomies, but we don't anymore, just Tylenol and Motrin, which on the parent side of things was really frustrating. And I did try the nurse card. I definitely tried to say, but I'm an ICU nurse, like I can give my kid, I feel comfortable giving my kid a dose of narcotics. And the nurse was like, I understand, I really do, but if you feel like she needs something stronger, you have to come to the emergency room. So being stubborn and not wanting to be the nurse that ends up back in the ER with my kid that wasn't drinking, I ended up going to the grocery store with her. I let her pick out any type of popsicle that she wanted from the popsicle aisle, and she managed to scarf down 2 before we got home. She peed right when we got home and had like the minimum amount of urine output for the day, and we were able to stay home. She was able to kind of catch back up from there once we got those popsicles in her, but whew, it was a rough go there. You know, and it's nice that I've had the perspective from both sides of things, of having been a parent, taking care of a kid with this procedure that's very, very common. As I mentioned, I've had patients in the hospital that have had very easy recoveries, and I've had patients in the hospital that have not. I've ended up calling rapid responses on kids that had post-op tonsillectomy complications. I have had a patient code post-operatively for a tonsillectomy, and mainly it's usually related to the upper airway inflammation and airway obstruction that causes complications with that. I had one kid that was bleeding really significantly and we had to take back in and cauterize. So it's nice to have those perspectives as a parent to be able to build on that and to tell families, yeah, I know Tylenol is what we tell you around the clock, but it may not be enough. It didn't work for us. So here's some things to try with your kiddo at home. And these are just some pictures from the process of having this done. This was at Children's South Campus, which is the one down in Highlands Ranch. So that first picture in the top corner here, this one is a little play set that was in the waiting room. So when we first walked in Friday morning, she's playing. This was in the wagon. This one's in the wagon waiting for us to go back. This one here, at the top right corner there, is in the pre-op room. So she came in, we put her little hair up in pigtails, we put her in her gown, and she knew right away coming in that was the process of what was expected because she'd gotten that prep on Thursday night before she came in on Friday morning, was able to go through the motions. She knew and followed directions. And then this one here is in the hospital. This was the overnight in the hospital bed. The blue tube that you guys see here, this tube that's kind of like here, this is humidified air. So it's not oxygen. It's just set up to the air on the wall, and it's got a washcloth wrapped around the end. That's what that white thing is, so to give it weight so that you can kind of position it around the head. So that's just humidification. It's like having a humidifier in the room at home. Cold air, right? Cold air, breathing in cold air reduces inflammation. So it can reduce airway inflammation, and it can also help with pain because if that inflammation is down, the airways are moister, they don't hurt as much and they're less likely to bleed. So that humidification is really important, whether that's in the hospital or at home. Having a humidifier is really helpful for that reason. And then these ones here and here are wagon rides. Kids love wagon rides. We have them all over the healthcare facilities and pediatrics. Pretty much every peds hospital that I've ever worked in has wagons. Kids love wagon rides. It's great for carrying all their stuff around. You know, they've got an IV. You can attach it to the pole there and wheel them around, or you need to prop them up on a pillow. They can sit in it. Aria liked pulling it, so you can see in that picture there that she's pulling it as she was going home. So wagons are great for kids. All right, otitis media, ear infections. This is pretty much the most common disease process that we see in kids, kind of secondary to colds, because this is usually triggered by a cold. And pretty much every kid before the age of 2 is going to get an ear infection. This is usually the kiddo that gets the viral illness. They get the upper respiratory infection. They get a cold, and then a few days later we'll start to see signs of the ear infection. So sometimes it's the fever that they had for a couple days with the cold. The fever went away and they seem to be doing better, but now all of a sudden the fever is back. And signs of an ear infection could be things like pulling at the ears, where the kid's just kind of like doing this thing, pulling at the ear, or sometimes it's them like rubbing at the ear, especially with little kids that can't verbalize, as they're like rubbing at the ear or like rubbing the head on the pillow. They may just be really, really fussy and irritable, and pain. An older kid can say, ow, my ear hurts. The younger kiddos may just be fussy and kind of playing with their ears. The otoscope exam, it's going to be a purulent discharge or discolored. It's not that nice pearly gray color. It's kind of red and inflamed and bulging looking. And if it does rupture, which does sometimes happen, there may be drainage coming out of the ear. So it could be that purulent discharge, like bloody purulent discharge coming out of the ear. Usually their pain gets a little bit better when it's ruptured. But no, it still needs to be treated. Management for this is going to depend on the underlying issue. I've got pharmacology antibiotics here, and this is something like I just mentioned with this tonsillectomies, is that we're using antibiotics less frequently than we used to. We used to just prescribe everybody with an ear infection antibiotics. Because most of these ear infections are triggered by a viral illness, many of these ear infections are not bacterial. They're viral in nature. So our bodies can fight them off once that virus is kind of recovered. But it sucks for kids, right? Their ear hurts. It's going to take several more days before they feel better. Culturing takes several days, so it's not cost effective or time effective. So what we generally do with the ear infections nowadays is say, okay, yes, you have an ear infection. Let's keep an eye on it. Motrin and Tylenol around the clock. If after about 2 days or so it's not getting better, then we can do the antibiotics. There are exceptions to that. Sometimes it's like, no, you need antibiotics now. But for a general healthy kid, new onset ear infection, not had recurrent ear infections, that's the general kind of management for it. And then surgery for kiddos that are having recurrent ear infections. I talked about the adenoidectomy being something we may throw in there, but we also do something called a myronotomy. So for kids that get frequent ear infections about 4, 5, 6 times a year, they get this little tube placed in the ear that helps with drainage. So when they do get all of those colds and coughs, it's not building up there. It'll drain out a little more easily. Now it is an opening into the ear, so they should not be swimming in like fresh bodies of water like lakes, submerging completely under the water. There's a risk factor for an ear infection there. And if they do get an ear infection, they need antibiotic ear drops to go in as well, with an oral antibiotic a lot of times. Prevention for ear infections: suctioning when kids have a cold, just clearing those airways. No bottle propping. What bottle propping is basically if like the kid's drinking from a bottle, parent puts them down into an infant seat and they put like a towel roll underneath their chin that'll hold the bottle, so it's just like, you know, propped up here so nobody has to hold it. No bottle propping. That, like, everything kind of drains back to those ears that way. And we do see an increased risk with families that smoke in the household, so we want to do some smoking education and help prevent that smoking in the household. And then this next slide here has a couple pictures on this next slide here. So this is a nice healthy eardrum. That's that pearly gray color that I was talking about. This one here has it's red and purulent drainage that you can see. That yellow here is that purulent discharge behind there. So if this were to rupture, you'd see that draining out of the ear. This is the myronotomy. It's a tiny, tiny, tiny little tube. This is blown up pretty big for this picture, but it's teeny, teeny, tiny. Usually we leave that in place for a few years if the kiddo's continuing to have upper respiratory infections. Once they're old enough, usually by about 5 or so, if it's still in there, then we'll go in and we'll pull it out, just little tiny tweezers, and kind of take it out, and the eardrum will close up over it because they're kind of past that age when they will get ear infections anymore. Okay, so now we're talking about Croup syndrome. So this is an umbrella term, right? Croup is the syndrome. There's a lot of underlying disease processes that cause croup. So we're going to talk about the most common forms of it, but there are other types that we're going to go over. And basically, they're all characterized by the same signs and symptoms, where patients get hoarseness, they get this barky, seal-like cough that kind of sounds like this. Inspiratory stridor, which will sound like this. When they're breathing in, it's inspiratory, right? When they're breathing in, and it's upper airway, right? It's up here. This is not a lower airway sound. This is coming from the upper airway. And respiratory distress, and depends on how significant their illness is, on what that looks like. Most of the causes of this, especially in younger kids, are viral in nature. So we're going to talk a little bit about what that looks like. We're going to talk about epiglottitis, and we're also going to talk about laryngeotracheobronchitis, which most commonly is caused by viruses. I'm not going to talk about acute spasmodic laryngitis or bacterial tracheitis, but they have very similar symptoms. So epiglottitis, this is common between our 2 to 5-year-olds, and it's bacterial in nature. We have a vaccine for this. So the Haemophilus influenza, H influenza B, or HIB, HIB vaccine, protects patients from this. So we don't see this very commonly at all in the United States because we have a vaccine for this. Now, we have seen a few more cases of it over the last few years just because vaccine rates have diminished over the last couple years, but this one mainly is preventable with vaccines. It is considered an emergency when patients get sick with this. It's usually a very, very rapid onset. These kids get sick with kind of cold-like symptoms, and then all of a sudden, it gets very rapid to the point where they're having respiratory distress. So sore throat, dysphagia, like their throat hurts, it's hard to talk. They have a muffled voice and pain, like their throat hurts. And then when they go into the acute phase, when it gets really bad and it starts getting worse, that cough goes away because their airway is now starting to tighten up so much. They start drooling because they're not swallowing anymore, right? That epiglottis is occluding their airway, and they're agitated, they're air hungry, they're kind of agitated. And it's not uncommon to kind of see them in that like tripod position where they're leaning over and trying to get air into the lungs. They have a tendency to be very toxic appearing, just look sick. They look sick. High fevers, very high fevers. These are usually 104 fevers. 103, 104 fevers. They have that inspiratory stridor, maybe hypoxic, and that respiratory distress, like retractions, especially suprasternal retractions here. So management for this kiddo, respiratory obstruction is a big worry for this kiddo. On an x-ray, we call it a thumb sign because it kind of looks like a thumb over the x-ray. If you like hold your thumb up to the screen, it kind of looks like a thumb over the airway. So think about potential risk of airway obstruction. If that epiglottis is occluding that airway, trying to put a breathing tube down the throat, it's just going to hit that resistance. So it's really hard to get patients intubated this way. Sometimes this ends up with an emergency tracheotomy for us to be able to breathe because we're going to put that tube in lower than where that obstruction is. Steroids are given to this patient. These are usually IV, and they are going to be rapid. Usually dexamethasone, IV immediately, right? So that we can get them in, reduce that airway inflammation. Oral steroids would take too long, and they may have trouble swallowing them, right? So what happens with the little kid? Remember I mentioned this is a 2 to 5-year-old that is sick with this in most cases. We do occasionally see it in older kiddos, but normally 2 to 5-year-olds. And if I go in to start an IV on a 2 to 5-year-old, it's most likely not going to be an easy process, right? They may kick and scream and cry and flail. That is not going to bode well for my airway. That can easily cause that airway to just and completely occlude. So before you start an IV on this patient, make sure that you have all of your emergency equipment, that you've got staff at the bedside. I would not go in with a kid like this to start an IV by myself. Absolutely not. I want to make sure that I have everybody in there. usually respiratory therapy, and everything's out ready to go. Because if that airway occludes, you want to be able to intervene quickly. So we get that airway in, we get the IV in, we get antibiotics into this patient as soon as possible. It's bacterial infection rate. And in most cases, this is going to be a kid that's going to end up intubated with an IV, with the steroids, with the antibiotics for a couple days until we get that infection under control, and then they go home. As long as we can maintain airway perfusion and oxygenation, these kids usually do just fine. Usually not a long course of treatment, but as long as we can maintain that airway, that's kind of the key thing there. We want to make sure that we're not putting anything near or in the throat. If this kid comes in with a description like this, do not use a tongue blade to assess that throat. You can shine a light in there, they can go and open up their mouth, but you don't want to put a tongue blade in there because that can cause that airway to occlude. And again, this is usually ICU management for a couple days. They're going to need quick, rapid care with their management. Then we've got laryngeotracheal bronchitis, so really long name, and this is most commonly what parents say, oh, my kid had croup. This is what they're referring to. This is more likely to be a viral infection, especially in kids under 5 years of age, and it happens more slowly than when we're talking about epiglottitis. This is usually a kid that gets the upper respiratory infection. They've got a cold, they've got inflammation, and a couple days later, parents start to notice this barky sounding cough. It's not uncommon for them to come into the emergency room and they're like, oh yeah, my kid has this weird cough at home. And they have potentially that inspiratory stridor and mostly upper airway issues as a concern here. And all of the different viruses that we see can cause this. For you and I as adults, because our airway is so much bigger, when we get tracheolaryngeal bronchitis, usually we say we have laryngitis, right? We have, oh, we can't talk and our voice is really hoarse, but usually we're sick for a few days beforehand. It's pretty much the same process. It's that infection, that virus that's causing inflammation of the laryngeotracheal area that's causing these symptoms to happen for this patient. So again, upper airway is what we're seeing with this one. And that could be things like that inspiratory stridor, that like sound, that squeaky sound as they're breathing in, not lower airway, upper airway. Suprasternal retractions, a lot of these suprasternal or supraclavicular retractions as they're trying to breathe and open up that throat. That barky seal-like cough. And it's really funny because a lot of times parents will be woken out of their sleep in the middle of the night and hear this. They'll hear their kid in the bedroom like making these weird coughing kind of stridor noises and rush them to us in the hospital because they hear it in the middle of the night, like 2 a.m. Classic 2 a.m. Increasing respiratory distress. Now, not every kid with croup will go into respiratory distress. It depends on how bad their airway is. Hypoxia can be related to that. If their airway is starting to occlude, they're going to become hypoxic. I have seen lots of croup patients. I am worried when they become hypoxic because this is not usually a lower airway issue, right? We still have nice O2, CO2 exchange that's happening in my lower airways. It's not something like pneumonia that's blocking that process. It's upper airway. So if they're hypoxic, it means that that air is just not getting in. That is a worrying sign for kids. It means that airway is just like tightening up really significantly if they're becoming hypoxic. Those are the kids that I'm like, yep, let's get the emergency equipment out because this kid may go downhill. It can progress to respiratory acidosis, respiratory failure and death if it's not managed. Most kiddos in the US, at least, as long as they have access to emergency medicine, will usually do okay with this, but it can progress to failure if we don't maintain that airway. And it's usually more of a slow progression versus epiglottitis is usually more like a sudden decrease. This is usually a kid cold, and then all of a sudden we get these croup symptoms that happen. This one's called a steeple sign on X-ray. So this is the steeple sign on X-ray. So you think about a steeple on a church, that tall point on the church, that's what you're seeing here on this X-ray, this narrowing down, this complete occlusion of this X-ray airway for this kiddo here. So management for this patient. Airway management is really important. Have your safety equipment at the bedside and make sure that your patient's staying oxygenated. Hydration, whether that's PO or IV, if they are having trouble breathing, they need an IV. Now, the same thing is true for this one as well. Nothing in the mouth, and you once you go in to start the IV, they may kind of freak out, and that can cause airway occlusion. So careful start of those IVs. High humidity with cool mist, that cool humidification, like I was talking about with the tonsillectomies, that cool humidification helps decrease airway inflammation, can help with those symptoms. Now in the hospital, it's really easy for us to hook it up to the wall, oxygen or air, and put that tube on my patient and humidify. At home, parents should be using a humidifier. Cool mist is better than warm mist for a couple reasons. Cool mist helps reduce airway inflammation. It also decreases risk of bacterial growth or fungal growth in the humidifier. If it's cold, like the heat encourages bacterial growth. As well as kids can burn themselves if it's hot, if it's a heating element. So the cool mist is good for a variety of reasons. Parents can do cool mist at home even if they don't have a humidifier at home, and there's a couple ways to do that. Because this is a lot of times associated with colds, we see it more in the wintertime. So I tell parents, bundle your kiddo up and go sit outside for a couple minutes, because that nice cold air will help reduce that airway inflammation and decrease their symptoms. It's one of the reasons why that 2 a.m. kiddo that wakes up and is like, symptoms, mom hears the weird cough in the middle of the night, rushes the kid to the emergency room, it stops by the time they get to see us, because they've been sitting in the car for the last 15, 20 minutes and their symptoms got better. So sitting outside or opening a window and sitting and breathing in that cold air. In Florida, when I used to work as a nurse in Florida, we used to tell parents to use the freezer, like sit in front of the freezer and open the freezer door and stick the kid's head in the freezer so that they could breathe in that nice cold air from the freezer. It's a little harder with the freezer drawers now to like stick their head in there, but the old school freezers with the one on top, you can do it a little more easily with. The other thing that can be done to help with humidification and decreased airway inflammation is getting the kiddo into the bathroom, closing the bathroom door, turning on the nice hot steamy shower, just letting it run. The kid doesn't even need to be in the water, just sitting in the room. You know how it gets all nice and steamy in the bathroom when that happens? Breathing in that steamy air, that cool air, and even if it's a warm ambient temperature, does help as well. And the symptoms should get better, should help a little bit. Heliox is sometimes used for kids with severe illness with croup, and that would be a patient a lot of times in the ICU that has significant airway obstruction. And then we also use nebulized treatments for these kiddos. Racemic epinephrine, especially for kids that have stridor at rest and they have more significant airway obstruction, racemic epinephrine will help decrease airway inflammation and decrease those symptoms. We also use steroids. If they're a mild case, if the patient just has a little bit of croupy cough, doesn't have any stridor, oral steroids may be just fine. If a patient has significant stridor and airway obstruction, then they're going to need the IV steroid to get in more rapidly to help with the management. Racemic epinephrine is something, though, once we're using it, it's not usually a home discharge right away. This is, the kid needs to be sick enough to be able to need racemic epinephrine as an inhaled medication. So I got an example of a kid that I had years ago. I was taking care of this kiddo, typical middle of the night ER patient, came in with croup symptoms. He got oral steroids because he was kind of mild when he first came in, and he got a racemic epinephrine dose. Racemic epinephrine has about a half-life of 3 hours. So if patient has not had rebound symptoms by 3 hours, then they should be good from there. But sometimes once the medication wears off, we get rebound symptoms, and we don't want to send that kid home assuming they look great at an hour, and then they get home and their symptoms get worse again. So if a patient has received racemic epinephrine for this, they need to be monitored for about 3 hours afterwards. So this kid gets put into a room. He's on the pulse ox. He's sleeping because it's middle of the night still. I go in, I'm reassessing, and about the 3 hour window, he starts having stridor again. So I called the doc, let him know. The doc orders another racemic epinephrine dose. We'd already given the steroid, so he gets his racemic epinephrine dose. And at this point, with 2 administrations of racemic epinephrine, he gets a hospital admission. Even if he does okay after the second dose, we want to make sure he doesn't go back downhill again. So we called for transport. I was working at one of the Children's Network sites, and we called for transport, and we're waiting for transport, and the kid's hanging out in his room. and I go back in to reassess him, and he only makes it about 2 hours this next time, and we end up having to give him another racemic epinephrine dose. Well, at that point, that kind of triggers an ICU stay for him, because he seems to be getting worse at this point. So we called for Flight for Life ground treatment to come get him. So we're waiting for grounds to get there, and about an hour later, after this last racemic epinephrine dose, he just crashes. He's having constant stridor. It's not going away. So we end up putting him on a continuous racemic epinephrine, inhaled, and that's pretty rare to do. It's not a common thing to give continuous racemic epinephrine. So he's getting this continuous racemic epinephrine. We called for the helicopter at that point, because we're like, this kid's crashing. He's not doing well. Most of our network sites, especially the smaller network sites, and a few years ago this was the case, we don't have an ICU. We don't have mechanical ventilation. So if we have to intubate a patient in those network sites and small healthcare facilities, you're handbagging, like literally like handbagging your patient until you get a flights team there to get the patient up to the hospital. So we called for the helicopter to come get him. And of course, flights gets there, and they're like, we can't transport this kid without an IV. And sure enough, as soon as we tried to start the IV, he's already agitated and kind of upset enough as it was at us. He ended up getting intubated. He went up to the ICU. Steroids had kicked in by this point. He spent about 24 hours in the ICU and went home. No complications, no issues. It was just a matter of that airway, right? That upper airway just being occluded enough that he was not able to breathe. Once that steroid kicked in, once that inflammation went down, he was fine. He was totally fine, was able to go home from there. But that's kind of the most extreme that you'll see with croup. A lot of kids with mild croup, it's home management, it's oral steroids, it's not usually a significant issue, but kids can die from this if that airway occludes and we haven't managed it. Okay, so now we're going to talk about airways of the or infections of the lower airway, and you may be a little bit more familiar with some of these as well from med-surg, like bronchiolitis. We're going to talk about a couple of things here. Remember that our lower airways are generally considered the sterile environment. It is more easy for kids to get things like viruses and bacteria from upper airway that normally get caught for us as adults, that get stopped from going into those lower airways down into those lower airways for kiddos. So a cold that turns into bronchiolitis, where they have lots of secretions and illness in their lungs. So bronchitis, this is inflammation of the large airways, right? Our trachea and our bronchi, primarily caused by viruses, but it can be things like Mycoplasma pneumonia. Something to think about in a teenager that is getting chronic bronchitis, maybe something like smoking. That's definitely something that is seen in more of a teenager. And kind of the classics with this one is this dry, hacky cough that has a tendency to get worse at night, and then it can become more productive after a couple days, where they get more mucus production and kind of sputum. And unfortunately, when those lungs are irritated like that, it can last for several weeks. So the virus may be kind of out of the body, but that irritation and that inflammation and the cough can last for several more weeks. So this isn't always an easy fix. And this one's mainly symptomatic management, suction, oxygen, humidification. If they need more significant intervention, that may be a hospital stay for them. Now, cough suppressants are not recommended for young kids, and the main reason for that is that they're weak. Their cough is already a little bit weaker to begin with. Think about the decreased muscle mass. So their cough is already a little bit weaker. So we want them to cough and clear those secretions. If we suppress that cough with something like a cough syrup, like a codeine cough syrup, then they're not coughing effectively, and those secretions are sitting in there and can turn into a pneumonia. So general rule of thumb on this is that we don't recommend cough syrup for young kids. Occasionally we will prescribe something like that if the kid is just coughing and coughing and coughing and coughing and they're not sleeping. Sleep impacts that. So they may get some mild cough suppressants if they're younger. A teaspoon of honey also works. Sorry, I was waiting for the ambulance to go by. Fire truck. A teaspoon of honey also works. So older kids than a year, a teaspoon of honey helps coat that throat and can help that cough from getting too bad, especially at nighttime when kids are trying to sleep. But when they're up and they're moving around, we want that cough. We want them to be able to clear those secretions from that airway. And our bronchiolitis, so this is the smaller airways of our lungs that have secretions in them, right? And it's very similar to bronchitis, except this is just smaller airways now, and it's caused by a lot of the same reasons. Viral illnesses, their most common cause, RSV, rhinovirus, parainfluenza, and this is most common in kids under 1 to 2 years of age. You know, my slide says 1. Pretty much every kid before the age of 1 is going to get a case of bronchiolitis, but kids under 2 are just more susceptible to severe illness with this one. It has a lot of mucus production in those lower airways. So the manifestations, the signs and symptoms: cough, sneezing, wheezing, fever, tachypnea, retractions, all the things that we see with a viral illness, and especially lower airway impact. And a lot of times the wheezing that comes with bronchiolitis is not necessarily airway inflammation per se, but it's also because of the mucus that's in there. And it's usually more diffuse, kind of all over the lungs, that it's being impacted and not just like one focal area like we would see with a pneumonia. So we can diagnose bronchiolitis viral cause by doing a nasopharyngeal wash, where we do suction and we send that away to culture it to see what type of illness it is. I think pretty much everybody in America is familiar with doing a nasal swab at this point, right? We can also do a nasal swab where we stick the Q-tip up the nose and we test for what viral illness it is. In the past, it didn't really matter. It did not matter if it was RSV or parainfluenza or influenza or COVID. A viral illness was a viral illness, and we treated it symptomatically. In most cases, we don't have antivirals that will help manage it. Because of COVID, we are basically testing pretty much any kid that has more significant illness for a full viral panel. It's not helpful to just do COVID at this point. It's if we're going to do the test, we might as well do the test and run for all of it. But it is kind of an expensive test. It's about $300 for the whole panel. And in most cases, again, it's just symptomatic management. Now, it's important for us to know for COVID for infection control reasons, but it doesn't really change the management of how we treat the infection, of how we manage the patient's signs and symptoms. So keep that in mind. Like, it's helpful to prevent the spread of disease and knowing what it is, but it doesn't really treat the underlying cause. Now, treatment does depend on what it is. In some cases, but most of the time it's symptomatic management with all the different viral illnesses. Oxygen, humidification, suctioning. Fluids are important for our patient. Make sure they're hydrated. If they're dehydrated, those secretions are going to be thicker. It's going to be harder to clear them, and it's going to make our respiratory compromise a little bit worse. Airway management for our patient. So suctioning I mentioned, and you know, we have the hierarchy of oxygen administration with patients, right? We've got things like the nasal cannula, and there's an infant all the way up to an adult size for nasal cannula. We've got a face mask. A simple face mask, you know, has to be run at least 5 liters. A low flow face mask can be run at a lower rate. We have non-rebreathers. Those are really only meant to be temporary used. And we have things like BiPAP or CPAP. In infants, we use nasal CPAP, so it goes in the nose, because remember, they're breathing through their nose, so nasal CPAP can be used. And then all the way up to an intubation, where we're doing potentially all of the work for the patient if they're breathing that hard. So airway management depends on how severe their symptoms are. Yes, kids with bronchiolitis end up in the hospital. They end up in the ICU. Patients with bronchiolitis die. So airway management and keeping that airway open and keeping them breathing is priority for this one. You know, airway, if you're thinking about ABCs, airway is a big one. Medications that may be used, pretty limited with this one. If it's flu, we may use something like Tamiflu, but it has to be within the first couple days of illness, right? If it's RSV, we may use a medication for viral illnesses, but it's not a common thing that we'll use unless the kiddo's like immunocompromised. Most of the time, Motrin Tylenol, suction, oxygen, humidification is the primary treatment for bronchiolitis. There is a vaccine for RSV. It is very expensive. It's about $2,000 a dose, and it's not accessible to every patient. And it is RSV, probably next to like flu and COVID, is the next most severe respiratory illness that we see. And unfortunately, because this vaccine is so expensive, it's not available to all patients. Kind of an FYI, just in adult medicine for this one, the RSV vaccine is being trialed in our elder adult population right now and has shown significant outcomes. And so they're talking about potentially making this a vaccine to give in, especially in senior living facilities where RSV spreads easily amongst seniors. And they're the higher risk population also that die from RSV. It's babies and older adults, just like the flu. So this vaccine, because it is expensive, is only given to high risk babies. So babies that are high risk. So this is going to be a baby that is immunocompromised, or a child that has a cardiac disease that puts them at risk, or a kiddo that is premature. So prematurity puts them at a higher risk of severe respiratory disease. So they usually get this once a month during respiratory season, during that first respiratory season and that first year of life, you know, December, January, February, March. They get one injection a month, and then they're usually good for that next winter. It's usually just that first winter. And as long as it is documented why they need it, why we're giving it to them, you know, they have an underlying disease process that puts them at risk, then the insurance companies will pay for it, but they don't pay for it or provide it to pretty much anybody else. All right, pneumonias. So you guys cover pneumonias pretty extensively in Med-Surg 2. I don't know if Professor Borman has this chest tube box at home, but he used to bring that into class and kind of show the chest tube box. Pneumonias in children are not really any different than adults. So I don't want you to think about this in terms of like, oh, it's a different disease process. It's the same. The main things that I want you to think about, the differences with pneumonias in kids, is just that increased risk because of their airway size and their decreased ability to fight off diseases or compensate when they get respiratory diseases. Inflammation of the pulmonary parenchyma is kind of the main thing that we see with pneumonia, and it can be caused by viruses, bacteria, funguses. Aspiration can cause it as well. So aspiration of a foreign body can cause a pneumonia. So there's lots of different reasons that we see this with kiddos. Organisms or susceptibility to organisms are going to be a little bit higher in some populations than others. For example, toddlers. I'm much more suspicious of a viral pneumonia than I would be of a bacterial pneumonia in that age group. An older school age kiddo, I'd be more suspicious about a bacterial agent than I would with the younger kid. So that sometimes helps us determine what might be the cause of a pneumonia if we haven't tested it or haven't done further investigation. The general signs and symptoms of pneumonia are general signs of respiratory distress. So all of those things that we talked about at the beginning of the lecture, fever, abnormal cough, abnormal lung sounds, retractions, diminished lung sounds, nasal flaring, pallor, cyanosis, the kid that's just fussy and irritable, or the kid that's lethargic. Those are all things that we see pneumonia. So how do we determine it's a pneumonia from everything else, from bronchiolitis? We could get an x-ray, and that's the easiest thing to do would be just, oh yeah, let's just go get an x-ray. Well, sure, but you don't always have access to an x-ray. If you're working in the school setting, you're working in a home healthcare setting, you're working in an outpatient setting, you may not be able to get an x-ray right away, but that doesn't mean we don't want to treat our patient. Lung sounds, your assessment is really key with this one. And once you get decent, you get a little bit more used to listening to lung sounds, it comes a little bit more easily. On the picture here, I've got this little guy with this right here on that left side. You see how it's significantly different on that right side versus the left side. So this is a right middle lobe pneumonia. If I'm listening to my patient with a pneumonia, with an area of consolidation, you're going to hear, in this kiddo here, I'm going to say clear, maybe a little bit diminished, maybe a few crackles. oh, we're listening over that middle lobe. That's where you hear the distinct difference. And you can go back and forth between the two of like, okay, this. Oh yeah, it's definitely diminished here. This is going to be diminished lung sounds, rhonchi, crackles potentially. And then it'll go back to being clear, potentially like minimal crackles, something along those lines. And the same side, this side is going to sound different than this side because there's no consolidation here. We get a little bit of extra fluid. I like to say it's just extra fluffy stuff in there. There's a little bit of fluid here, but it's not enough to cause an alteration in your lung sounds. Versus bronchiolitis, if you have a kid with bronchiolitis, it's more diffuse. It's kind of all over the place. Sometimes it moves because the kid coughed and cleared and those secretions kind of moved around. With pneumonia, though, with that area of consolidation, it's not going to move. It's going to stay here wherever that pneumonia is. So that's one way to help determine where it is that you're listening, what it might be, a pneumonia versus bronchiolitis, because they're very common things in kids. That we're listening for. And then one other thing that I've kind of going to point out down here at the bottom, things like abdominal pain can be more easily appreciated in kids. They may say, oh, my tummy hurts more than adults will. We may be able to focalize our pain a little bit more effectively than a kid can. Kids are more likely to also get referred pain because they're short stature, just everything's kind of close together. They may get more referred pain, like abdominal pain, even if it's a chest issue here that they're having, their tummy hurts. Okay, so treatment of a pneumonia. This really is also no different than your adult populations. Rest, hydration, antibiotics as appropriate. If it's a bacteria, give with antibiotics. If it's viral, maybe an antiviral medication like Tamiflu, but otherwise it's going to be symptomatic management. Chest tube, as needed. If there's an area of consolidation that we need to drain, we're going to manage with a chest tube. Now, key things that I want you to think about. We're not going to go back through chest tube management. We use the exact same boxes. We use chest tubes in peds patients, and it's managed the same way. Things like making sure that you have a good seal around your chest tube. The main difference is the size of the chest tube. The tube itself, the diameter of the tube itself is going to be much smaller if they are a peds patient, especially a younger peds patient. Now, this is an example of a workaround with the chest tube that we had in Uganda, where we did not have that like nice occlusive dressing that we were able to put. But you see how you have a flap and, for venting here for this kiddo, and the chest tube size is going to be much smaller than you would see with an adult. Oxygen is needed. That can be all the way up to potentially intubation, depending on how bad it is. And then the other thing that I've got here is positioning on this one. So old concepts on this for positioning was good side down. It helps splint. It helped decrease pain on that side where the pneumonia is. Now, the new recommendations for this, the American Academy of Critical Care Nursing says that the good side down, bad lung up. And this helps prevent VQ mismatch. Basically, this is helping us aerate that bad lung so that we can get that oxygen in there, get things moving around, and we can prevent that VQ mismatch. So what I want you to know this new protocol, right? It's not about pain. We can give pain management. If they're having pain, we give pain management. What we really want to improve really is their oxygenation, and decreasing that VQ mismatch is your priority, right? So good side down, bad side up. Just like the picture, good side down, bad side up. All right, tuberculosis. So this is one that you should be familiar with for med-surg. You know, a lot of similarities with our pediatric population. However, the big thing that we see with peds is that they're not a significantly large population of patients with TB, especially in the United States. Only about 5% of all TB cases that we see in the US are peds. And a good chunk of those, 25%, are foreign-born children or kids that come from families that are immigrants. They're just larger percentages of patients with TB in many other countries. So we do see a higher incidence from certain populations. There is some link with families that have unpasteurized milk, or farmers in general, especially in rural Colorado, where they're maybe drinking unpasteurized milk. If a cow has TB, it can be passed that way. So that's one risk of transmission, but it's a pretty rare risk. Generally, kids also have a decreased rate of transmission to others because they do have a weaker cough. They're less likely to transmit it to others just with that cough and aerosolizing it out into the room. And I want you to think about populations that are a little bit higher risk with TB, with getting severely ill with tuberculosis. And that would be patients that are immunocompromised, infants, especially premature infants, and any patient with like a cardiac or a respiratory disorder is a little bit higher risk. So clinical manifestations of TB in our peds population are the same that you would see with adults. They get a fever, they get malaise, they're fatigued, anorexia, weight loss, and cough, especially with bloody rust-tinged kind of sputum, the night sweats. And the one difference that we see with kids is that it can contribute to delayed growth or failure to thrive as well for peds patients. So treatment is going to be weight-based dosing of the same medications that we do use for adults. Isoniazid or pyrazidamide are kind of the primary medications that we use, and that's going to be 9-month therapy that's twice a week, direct observational therapy, or daily. If they have the resistant form of TB, rifampin would be one of the primary medications that we would use. Kids are less likely to have the resistant form. At least in the United States, we see less cases of resistant TB. Unfortunately, countries like India have much higher rates of TB that's resistant. And unfortunately, there is a form of TB now that has developed the last few years that is 100% resistant to all current treatments for it, all current treatment, so it's uncurable. Fortunately, that has not made its way to the United States yet, but it is time telling on if and when that does happen. Now I've got school at the bottom of the slide. One thing I want you to think about is that school is a primary goal for children, to make sure that we keep them in school. So if the patient is on meds or has latent TB, then it is okay for them to get back into school. So we don't keep kids out of school long term. Usually within the first week of starting antibiotics, we can get them back into school. And just in general, because TB is not a huge problem in the United States, I want you to think about the global impact of tuberculosis. And these are a little bit older statistics, but this is still pretty relevant to about what we see nowadays. So in 2013, 550,000 kids became ill with TB, and of that, about 80,000 children worldwide died of TB. So it's a pretty significant impact in general for a pediatric population worldwide. All right, foreign body aspirations. So any kiddo that has a risk of feeding difficulties, that coughs or chokes or gags when they're feeding, is at risk of aspiration, especially children that have altered level of consciousness, altered mentation, dysphagia, trach, feeding tube issues. They may be at risk of aspiration as well. So think about feeding techniques that you've talked about in med-surg, things like making sure that the head of the bed is elevated when they're feeding, making sure that the food and the liquids are thickened to the appropriate consistency. We use the same thickening agents for patients to make sure that their fluid is thickened, whether that's honey thick or nectar thick. There was one time years ago that I had a teenager who really wanted a Coca-Cola thickened, and I've never done Coke before. Mainly it's, water or formula, whatever it was. So I was like, okay, all right, I'll try this and see how it goes. I attempted putting the thickening agent into the bottle with the Coca-Cola. Did not go so well. The Coca-Cola exploded all over the nutrition room. So, yes, lesson learned. What actually worked in that case was like a little bit in the cup and a little bit of the powder to mix it to the consistency, and just like kept going like that. And it's really interesting trying Coke or drinking Coke that is thickened. It's like kind of like Coca-Cola flavored Jello is kind of what it was. Tasted good. So make sure that that's appropriate. And teenagers, want to do the same thing that teenagers do. So any liquid that they're drinking, as long as they're not on specific precautions, can be thickened. Younger kids, remember that kids under 3, everything goes into the mouth, so they're at even greater risk of things like aspiration and things that we talked about with ingestions, like toys or coins or button batteries are things that kids ingest, and they can accidentally be aspirated. And I've got in the picture here a quarter that, it's the perfect size for an airway for little kids. The coins get swallowed and they get stuck in that airway because they're perfect sizes for those airways. So I want you to think about airway is a big one with these kiddos. And this one here is a button battery. Button batteries cause significant tissue necrosis. They can completely erode through an esophagus if they're stuck. Some kids have no issue with it. It'll pass completely through their GI system, but when it's aspirated, it can cause some significant issues in their respiratory system. Other commonly aspirated things that we see with kids, oils can be aspirated pretty easily, and we have seen an increased incidence in those because like essential oils have been used more frequently with parents for different things. So making sure that parents are not giving straight oils is important. Talcum powder or baby powder, anything that if they're putting it on the kid and they're doing this to it, it aerosolizes. You take a good deep breath at that time, you're breathing that in. Food products are another common one. Nuts are one of the most commonly aspirated foods because kids just don't chew them up very well. Whole nuts should not be given to kids under about 3. Nut butters, almond butter, peanut butter, those are fine, but not whole nuts until about 3 years of age. But things like hot dogs and grapes need to be cut up into irregular shapes. You can't just cut a hot dog up into like little circles because those circles are a perfect airway occlusion. So cutting it in half and then cutting it up into those like semicircle shapes, they aren't airway occluding sizes. Small toys, like I mentioned, and the button batteries, like we just talked about, are more commonly aspirated substances. Okay, acute respiratory distress syndrome. So this is a quick touch on ARDS. This is more of an ICU level management. Remember, this class is more about beginning basic nursing for pediatric patients, but we see acute respiratory distress syndrome as one of the more common ICU admissions for pediatric patients because respiratory compromise is one of the most common causes of morbidity with kids. So basics of this, without getting too deep into the pathophys, we have increased permeability in the lungs, right? So that increases the fluid buildup that happens, that pulmonary edema that happens in our lungs. And it can be related to anything that causes endothelial inflammation and damage in the lungs that immune system is going to respond to. So that could be an infection, respiratory, bacterial, or a viral infection. It could be smoke inhalation, like from a fire, near drownings, sepsis can cause it, drug overdoses, aspiration of something. Are common causes of this. So lots of different things cause it. The lungs basically become stiff, full of fluid, and they're hard to ventilate. Those alveoli are blocked. We can't do that exchange of oxygen, and we have a hard time ventilating our patient. So treatment really depends on what the underlying issue is, and figuring out what that underlying issue is really important to helping correct it. There's an upwards of 50% mortality with patients once they develop ARDS. So being able to reverse that underlying cause is an important factor in helping them recover, helping them be able to recover. So if it's bacterial, getting them on antibiotics, and then maintaining airway, opening that airway up and maintaining airway. And that can be done with that variety of oxygen that we've talked about, all the way up to mechanical ventilation. We would be using nitric oxide. It could be something like high frequency oscillator or even ECMO. So high frequency oscillator, it's a type of mechanical ventilation that uses constant descending pressure, like mean airway pressure MAP, with oscillating variations around that MAP. So they're kind of giving this constant pressure and then it kind of is going up and down from there. And these can go upwards of 900 a minute, so it's really, really fast. Walking by a room with one of these running, you'll hear this like sound, and that can be how fast those breaths kind of around that mean airway pressure is going. Really small tidal volumes, but remember these lungs are hard to ventilate. They're stiff and hard to ventilate. So small tidal volumes helps us get what we need for the lungs when they're in that area. Of like just inability to ventilate appropriately. Usually these patients are also in the prone position. ECMO is something that you may have heard a lot more in reference to our patients with COVID. We're using this a lot more frequently with the adult patients. And kind of an interesting note about ECMO is that it started with kids. It really started in the NICU with premature babies, and then it kind of worked its way up to older kids, and now it's being used in adults quite a lot. And it stands for extracorporeal membranous oxygenation. So it's basically like bypass for the heart, but bypass for the lungs. So we're bypassing the lungs that are just not working very well. Maybe that's because they're full of fluid, they've got a pneumonia, and they're not able to ventilate, right? So whatever the reason is, this patient is having a machine do the work of the lungs. The patient's still going to be intubated. You still see in this patient here, they still have a breathing tube in. We still need to ventilate and move those lungs, but we're not relying on the lungs to do the work, right? The machine is doing the work of the oxygenation, deoxygenation. And you can see in this patient, we've got an arterial line, this nice bright red one here, and you've got a venous line, which is the dark one here. It's going into a machine. The machine is doing that perfusion and kind of bypassing the lungs basically, and that allows those lungs time to rest and heal, but the body is still going to get perfused. This is usually, at least in pediatrics, this is usually a 2-to-1 ratio, meaning that there's 2 nurses that are assigned to a patient that's on ECMO, and it's also usually a specialty training that if you are an ICU nurse, a PICU nurse, then you're going to be even further trained to be a PICU ECMO nurse or cardiac intensive care ECMO nurse. It's further training that's needed. Okay, so we're talking about asthma next. Our prevalence in the US since about 2015 hasn't changed too significantly. So it's about 8.5% of kids have asthma. It's a fairly decent number. It's a chronic inflammatory condition that can be triggered by a lot of underlying things. And we get the same primary symptoms across the board for kiddos with asthma. They have wheezing, they have shortness of breath, they have chest tightness, cough. And that cough, especially at night, and this is true for kids that have even mild cases of asthma. It may be a kid that like every night that they're getting put to bed, they get this cough that gets triggered. And that could be exposure to things like dust mites in the bedroom that kids, when they go to bed, they're getting exposed to, and that can trigger their asthma symptoms. The symptoms are coming from 3 underlying things that happen with this inflammation. They get bronchoconstriction, they get bronchospasms, and then they get increased mucus production in the lungs. And that causes things like that cough and the chest tightness and the wheezing. In kids under 2, if they're under 2 years of age, it's called reactive airways disease, or RAD. And that's, sometimes just related to immaturity of the lungs. When kids are a little bit younger, we don't officially diagnose them as asthma until they get a little bit older. There is also sometimes this misconception that kids with asthma can outgrow it. We never really outgrow asthma. It's a chronic inflammatory condition. Their symptoms may be under control, and a lot of times we do see patients sometimes as they get older and that immune system gets a little bit more mature that they don't trigger as easily, but basically the lungs always have a risk factor for triggering. So it could be something like, a patient that's been fine for years and all of a sudden they get sick with COVID and they have this wheezing and this asthma production that's going on because the asthma just never fully went away, right? There's no such thing as like officially outgrowing asthma. It's always a risk factor that we should list for our patients. One of the things that we use in pediatric patients is a pediatric asthma score and card, and this is a basic example of what one looks like. For the most part, they look about the same everywhere. We've really tried to standardize asthma treatment across the country, and this is one of the ways at the bedside that we have done that. So as nurses and respiratory therapists, I have a child that comes in with asthma. I can do an asthma scoring card on them. And depending on how bad their symptoms are, I can initiate treatment based on standard orders, right? I have a standard order that says if their score is less than this number, you can go ahead and start treatment. And in the emergency room, that's really helpful for us sometimes when we have a kid in, let's say it's a really busy day and we have a kid that comes in an asthma exacerbation and they know they have asthma, they've tried the standard treatments for it and they just need a little bit of extra help. And we have standard orders in place that says, patient score is less than 7, then we can start treatment on. Before the doc even gets in there, I can go ahead and start their treatments, which really does help address this faster than later. And these are easy to use. Basically, this one's really similar to what you'd see at Children's here locally. You've got a 0 to 1 to 2 point system, and they get a point for every category. So let's say their room air is less than 90%. They get 2 points for that. Wheezing. Is it inspiratory, expiratory? Is it just expiratory? So basically, you just go down each of these categories, give them a score. The higher the score, the worse the patient's symptoms, the worse off they are. Okay, medications for our asthmatics. So I'm not going to spend too much time on these. These should be medications that you are familiar with from pharmacology and prior classes. We use pretty much all the same medications in our peds patients. There are a few exceptions to that, but the general ones like albuterol, it's going to be weight-based dosing for our pediatric patients. And we have quick reliever medications as well as long-term medications. So it just depends on how severe their symptoms are, on which kind of medication that they're going to be on. Really, kids that have mild asthma, they're just going to be on maybe quick reliever medications. So if they are triggered by exercise or they're triggered by a cold, they may only need to do something like albuterol or Xopenex when they are sick or before activity, like before soccer, whatever it is, right? Or the springtime when they have more seasonal allergies, they may have to use it more frequently. Kids that have more uncontrolled asthma, more severe asthma, they're more likely to be on a long-term medication, like something like Singulair or salmeterol is a long-term inhaled bronchodilator. And the kids that are on MDIs, the metered dose inhalers, I've got a picture up on the slide there. You know, in adults, you may have seen the face mask or the spacer that has just this here. Right, so it's got the tube that goes in the mouth, so they get a tight seal around it, put it in, they get a tight seal around it. An older kid can do that, right? And a school-age kid and up can reliably do that. Even a 5-year-old, sometimes a 4-year-old can also do those skills. But a 2-year-old, like the picture here, is not going to be able to do that, right? They can't get a good tight seal around there. So younger kids that are using metered dose inhalers with their spacer, we recommend spacers for all peds patients, really even adults should be using spacers, have a face mask that goes on there. And this one is adaptable to both, right? The face mask just goes on there. And really, you just want a nice seal with this soft mask on here. So you put it around the nose and the mouth, and you get a nice tight seal there. So this helps for the younger kiddos. And they like to help. Sometimes they'll help hold, but you want to make sure that there's a nice good seal around that nose and the mouth. As well as something like a nebulized albuterol, and I've got the picture up here. This is my daughter. I've mentioned before, I think in class, that she has asthma, and the younger kids, again, can't put that blue tube that you may have seen with nebulized treatments in their mouth, so we use a face mask, and it just gets attached to their face, and they breathe it in. You want to think about the same things. You want them sitting more in that upright position. You want them taking nice, slow, deep breaths. Unfortunately, kids that are younger have a tendency, when we put these inhalers on them, they'll start like hyperventilating and getting a little more like with the treatment. Sometimes they're taking good deep breaths, sometimes not. Giving them instructions, even if they're not listening to you, kind of talking through the process of like, okay, slow your breathing down, try to breathe with me, watch what I'm doing, and try to get them to take slower, deeper breaths. Kids sometimes start crying. Sometimes I have to hold kids with this nebulizer down to get their breathing in. If they're crying, they're generally taking good deep breaths. Usually when they're like, you know, that's helping get the medication in sometimes. The metered dose inhalers with the spacers. With adults, we teach patients to take a slow, deep breath out, and then when you do the puff, like your inhaler here, you put it in, and you do the puff, and you hold your breath. So, and take that nice deep breath and breathe it in, and then hold it. Young kids can't do that, right? The little kid, this 2-year-old in this picture, is not going to be able to follow that level of direction. So what we do with the little kids with the spacers, especially if you're using the face mask, is to watch their breath. So for every puff, so if you do puff, five nice deep breaths. So 5 breaths. If they're doing 2 puffs, it's 1 pump per 5 breaths. So you don't want to do pump, pump, 5 breaths. You want to do push, 5 breaths, push, 5 breaths. So 5 breaths per push there. With these meter dose inhalers. Other medications to think about with asthmatics, things like corticosteroids, and these could be long-term inhaled, like Flovent, could be a long-term daily, twice-a-day medication. Remember, it is something that comes with the risk of things like thrush if they're not brushing their teeth or washing their mouth out. Little kids, I just told family members to brush their teeth afterwards. That way it washes their mouth out. An older kiddo can swish and spit. Even just taking a drink of something afterwards can help flush it out of the mouth, basically. Dexamethasone, if it's oral or IV, is usually reserved to things like an asthma exacerbation where they are having poorly controlled symptoms and they're having to use their inhaler frequently. Then we may give them oral or IV steroids or a steroid first. We also use medications like mag sulfate. It's a muscle relaxant. When patients that have asthma are so shut down and those lungs are so tight and full of mucus, it's hard for these medications that they're breathing in to get where they need to be to actually work effectively. So by giving that muscle relaxant, it helps release those bronchospasms, help open those airways up a little bit more. And then things like the albuterol can get in there a little more effectively to do what they need to do. But if a patient is needing mag sulfate, that's usually going to be an ER or an ICU admission for this patient because they're pretty sick by the time they're needing more higher level medications versus like their 2 puffs of albuterol. So when they're in status asthmaticus, this is a medical emergency. They are air hungry. They are struggling. They may be in that tripod position where they're bent over and trying to take a deeper breath. They may be sweaty. It's not uncommon for them to say things like, I'm going to die. I'm going to die, because they're just that like air hungry and agitated. And it can result in death if it is not controlled. I unfortunately have had parents that have brought their kids in too late in that process. And once those lungs are shut down, it's hard to reverse. I could put a breathing tube in for an asthmatic, but if those lungs are so tight and closed down, that breathing tube is not going to help me, right? The lungs can't do what they need to do. So relieving symptoms really early on in the asthma process is very important to prevent this, and parents recognizing how severe those symptoms are and being able to treat it. Concurrent infections are one of the most common triggers of status in patients. So a cold, getting the flu, can trigger a patient to go into status because they've got all those complications of the flu itself, the fluid buildup from the flu, plus we've got this inflammatory process that's going on that can make things really, really hard to manage. So our goals for asthma management: avoid those exacerbations and allergens. That could be something like wearing a mask or a scarf around the mouth during a cold day. When it's really cold, breathing that cold air can trigger asthma, bronchospasms. Pets. Did they just get a new cat? That's a common one, unfortunately, is the asthma starts triggering when they get a pet in the household. Seasonal allergies, or is it exercise? Kind of thinking about what those things are. Now, if exercise is an exacerbation, we don't tell kids to not exercise. We want them to exercise. We want kids to exercise, but we want to come up with safe ways to do it. So if they need to take a couple puffs of their albuterol before they go out to exercise, then we need to monitor that and see, is that effective? We want kids to have a good quality of life, and sometimes just one medication is not enough for that. So figuring that out for kids is helpful. Relieving their symptoms as soon as possible. That includes those bronchospasms. So starting treatment as soon as they start getting a cold and cough. Sometimes parents are like, I just thought it was a cold. I didn't think it was that big of a deal. And then by the time they present to the emergency room, they didn't start treatment right away when that cough started. If they're unsure whether it's asthma or not, it's better to treat than not treat. Peak flow meters are used in peds patients. 2-year-olds aren't going to understand peak flow meters. You have to be able to follow directions to be able to use them appropriately. Peak flow meters are measuring tidal volumes, and so it's going to be weight-based. It's going to be age-based for our patient. So that's going to change a little bit more than it would be for an adult. And you can see on the slide here that there's a kiddo here that's school age that is using this peak flow meter. So by school age, even maybe a 5-year-old is old enough to understand how to do a peak flow meter and do it effectively. And then the same thing for self-management of the inhalers, the devices, activity regulation. The 2-year-olds, again, are just not going to be able to help regulate this themselves. They have to have parents and teachers that are very aware of everything that goes on with them. What are their triggers? What do they do? How long do their symptoms last? Figuring that out. Management of their inhalers and devices. These should usually be kept in the nurse's station. There are some kids that are old enough to kind of manage it and keep it in their own backpack, but that's usually older kids. School age and up is when we reliably say kids have the cognitive function to be able to do their inhaler themselves. Younger kiddos, like the 2-year-old, should help in the process so that by the time they're hitting school age, they can more effectively do these treatments. So for example, think about the developmental level for a 2-year-old. What's something a 2-year-old could do? They can help hold it. They might be able to help push it down. Sometimes it's really hard to get these to push down, but they can help push it down, right? Like they can put their fingers on top of the adults and help push it down. They can help count. And when they're holding their breath or they're breathing those nice 5 breaths, I use fingers. I'm like 1, 2, 3, and then, count with my fingers. So slowly giving them more freedom with that and counting how many puffs did we do? Did we do 1 puff, 2 puffs, 3 puffs? To give them more freedom over it. By school age, they should have a decent understanding of how to do it. And should be able to do it with adult supervision. By adolescents, they absolutely should be able to do it by themselves without any issues. And then an asthma action plan, we're going to talk about that here in a second. This is something that we have to send home with every family. Okay, so this is what an asthma action plan looks like, and this is actually required that any patient that comes in with an asthma-like episode, wheezing episode, gets sent home with an asthma action plan. This is kind of required by your accrediting bodies. So asthma action plans make it easier for families to follow the directions when they go home. Sometimes it is hard to say, was their symptom bad enough to need this or that, and just kind of being able to follow that. So that way teachers, coaches, parents, anybody that's caring for this kid can have a little bit more of a straightforward plan of what to do if the child has symptoms. And basically this gets filled out and signed by the physician at either a doctor's office or an emergency room visit. And green zone means they're good. This could be the kid that only has exercise-induced asthma. So for exercise, we would put something like albuterol, 2 puffs as needed before exercise. Or the kid that, has seasonal allergies, maybe something listed here. They're not really having any symptoms, they're not having any issues. They could also be their daily medication if they're on Flovent daily. This could also be listed here, right? We want them to stay good in the green zone if they're on those daily medications. The yellow zone is if they are having symptoms. So the first sign of a cold, they start getting a cough or chest tightness, they're having those symptoms overnight, that nighttime cough, this would be an increased dosing. So it could be something like albuterol, 2 puffs as needed for cough or at first onset of illness. And then red zone down at the bottom here is when patients really having trouble breathing. They've tried their medication, it didn't work, so they can do another dose. They're starting to have retractions, they're tripoding, they're having more significant respiratory distress signs and symptoms. They need to seek health care. And I've had parents that come into the ER, it's 2 a.m. They were trying to manage it at home because they didn't want to get the kid out of bed or all of the kids out of bed to take them to the emergency room because the kid was having asthma exacerbation. It just can be too hard to reverse those symptoms once they already start down that path. So it's really important for families to be able to recognize this. Okay, we've tried 2 treatments at home. It's not working. Let's go get seen. Now, everybody that's in charge of this kid's care needs one of these. And this is something that is one of those high flagged items for daycares, for schools, so that teachers, especially for little kids, are aware that this child has asthma and what to do for them. Where's that inhaler? What to do if they have symptoms. So as I've mentioned, my daughter has asthma. And when she was in preschool, she was at a preschool that had this like Friday night parents' night out, and you paid extra. They kept the kids after the daycare program and kept them until 10 o'clock at night. Well, my husband and I had done this one Friday, and I get there at 10 o'clock to pick her up, and I walked into the room and I heard this tight, like, just this frequent cough that was really tight sounding. And I walk over and I look down, and my kid's laying on the mat, not sleeping, just coughing and coughing and coughing. She looks really miserable. So the teacher comes over and she's like, yeah, she has a cold. She just is coughing a lot. She hasn't been able to sleep. And I instantly was like, this is a cold, but this is an asthma attack. She has asthma. Has she done her inhaler? And the teacher kind of looked at me horrified and was like, no, I didn't know. So what ended up happening was that daytime person that was watching her didn't pass that information off to the nighttime person. We talk about the importance of handoff in the healthcare setting, of making sure all that important information is handed off to the next person. That step was missed. And as a nurse, I should have known better. I should have asked if there was a policy in place for this, but I had made the assumption that there was. And so that information hadn't been passed on. And she was retracting and she was coughing frequently. So I gave her an inhaler right then and there, and got in the car and drove her home because we lived just a couple minutes away. But she honestly was bad enough to the point, if I had been a non-pediatric critical care nurse, I would have been calling 911. Like, she was in pretty bad shape by that point. And I got her home, and we did back-to-back nebs at home like we would have in the emergency room, and was able to reverse that process, and she didn't end up having to be hospitalized. But we have ended up in the ER a few times with her. Needless to say, I was very upset by this process, and ended up on Monday having a discussion with the principal, and they ended up creating this handoff process for the daycare specifically, so that anytime, even if it was something like they're out on the playground and a different teacher is watching the kids out on the playground, that they've identified who has significant health risks like asthma or food allergies that they need to know about, and pass that process on. So, lesson learned as a nurse and a parent, to make sure that this information is kind of really clear to families, because not everybody is as vigilant about it as others. And kids can die from this. So it's really, really important to make sure that information is passed on. All right, cystic fibrosis. So this is the last disorder we're going to talk about in this section here. This is an exocrine gland dysfunction. It is a multi-system problem. It causes problems throughout the entire body. It is the most lethal genetic disorder amongst white children, so Caucasian families that we see this with, though we do see some populations in the United States that have mixed inheritance. Approximately 3% of the U.S. are symptom-free carriers. This is an autosomal recessive trait, so if both parents are carriers, they have a 1 in 4 chance of having a child with cystic fibrosis. So that's per pregnancy. This is a 1 in 4 chance per pregnancy. So if they have 4 kids, all 4 kids can have it. It could be 1 of the 4, but it could be all 4 kids. So it's a 1 in 4 chance per pregnancy. And the incidence for this is about 1 in 3,500 Caucasians born with it in the United States. So that's a decent number that we see. For example, in our African American population, we see about 1 in 15,000. So much, much lower incidence than we see in certain populations. That's probably the most, where Asian Americans are like 1 in 30,000, and Native Americans are about 1 in 10,000. So there are some mixed inheritance rates that we see with this, but mostly Caucasian population. I have a really great video on the link here, the CF One Republic at Red Rocks. This is a nice Colorado video with One Republic doing some cystic fibrosis education and outreach with a child who is now an adult. He would be 22, I think, this year, 23 this year. That filmed this video. I can't play it on a recording, or YouTube will flag it as a rights. So pause this one, go click on that link on the PowerPoint slides and watch it for a couple minutes for me. Think about, one, the population that we're working with. Socioeconomics are a big factor when it comes to a lot of things in healthcare, and having access to healthcare makes a difference in whether a patient survives or not. So keep that in mind when you're watching the video. And he talks through some of the treatment methods. There's some videos of him going through the treatment that I want you to think about as we're talking about this disorder. So the underlying pathology behind this, so basically this is increased viscosity of mucus glands, and we have those mucus glands anywhere in our body, right? All over the body we have these mucus glands. So in our lungs we have thick, sticky mucus that basically encourages things like atelectasis. It encourages bacterial and fungal and viral growth in our lungs because things can get stuck down there a little bit more easily. In our pancreatic ducts, basically the pancreatic ducts become blocked because of this increased viscous of those mucus glands. So things like your pancreatic enzymes can't reach the intestines, so that causes problems with nutrient absorption. And in the small intestine specifically, we can absorb things like our fat and our proteins. So really important things to think about would be growth for this patient. They also have problems, a little bit of problems with the autonomic nervous system. They have problems with their sweat, specifically sweating on a lot of their sodium chloride. So their electrolyte imbalance can be impacted as well. So diagnostics for this is something that we do test for in all 50 states. We do something called a Guthrie heel stick test, where we take little drops of blood and put it on this little white card, and we send that away. And we test for a lot of the most common genetic disorders of childhood, of infancy. And catching that early has been really helpful for improving life expectancy for patients with cystic fibrosis. Other things that we see with kiddos that have CF can be things like delayed puberty. Sometimes it's sterility. I actually had a teenager who was 19. He was technically an adult, 19, that came in for treatment. He'd had chronic lung infections his whole life, but had never been sick enough to need to be tested, or their primary care doctor, to be suspicious that he had cystic fibrosis. And it wasn't until he got married at a young age and was trying to have a child with his wife that they weren't able to, that he got tested for it and found out that he had CF. So usually it leads to sterility in boys, but females have an increased risk of infertility as well. We can test using a quantitative sweat chloride test, and that was something that we used to do before we had genetic testing for this. Basically, we would have the patient sweat in the controlled lab setting. We'd collect the sweat, we test it for sweat chloride, and for greater than 60 milliequivalents equal to cystic fibrosis diagnosis, basically. Chest x-rays, pulmonary function tests are done, stool enzyme fat studies, barium enemas, because they're at risk for things like bowel obstructions. And we can also run blood tests for genetics as well now, not just that little heel stick test that we do in infancy, but also older kids, we can do more genetic testing. The heel stick test only tests for the most common forms of cystic fibrosis, but there are a few mutations that aren't tested for that the child may still have that we can test for with blood. So a respiratory progression is a problem for these guys. This is gradual progression following chronic infections, that their lungs basically will get more and more and more damaged. So that bronchial epithelium gets damaged, it becomes fibrotic and stiff, and it can cause things like pulmonary hypertension and pneumothoraxes, and decreased O2-CO2 exchange. Basically, these patients get a COPD-like picture. We don't really see COPD in kids, but this is a kiddo that will get the COPD-like picture where they get that air trapping in the lungs, they get that barrel chest because of all that dead airspace that will start to happen because of those damaged lungs, that fibrosis in the lungs. So this is a chest x-ray, kind of a typical cystic fibrosis chest x-ray. A couple things to note in it. I know you guys don't get a lot of exposure to reading chest x-rays, and we don't expect you to. It's not something you're going to be expected to do when you get out. But you will occasionally look at them and be able to make an educated guess about what the diagnosis might be for this kiddo. And remember I mentioned with the pneumonia patient, the white areas indicate fluid in the lungs. So you can see how there's a lot of like these little fluffy spots, these little white, patchy, kind of cloud-like spots in the lungs here, right? This is fluid in these lungs here. And basically kiddos with cystic fibrosis always have some degree of mucus that are trapped in the lungs because it's so thick and sticky. It's kind of always there. It comes and goes. There's periods of good days and bad days for kiddos with CF. The other thing to note here is that the lungs are expanded very high up in the chest. Normally our lung expansion is not as high up into the shoulders here, and that's that barrel chest, that air trapping that's kind of hyperinflating those lungs that will cause that barrel chest appearance for these kiddos. So your respiratory assessment, frequent respiratory infections are something we see with kids. So we want to make sure that we're assessing their cough. Is it dry? Is it productive? Is it frequent? Is it occasional? Has it gotten worse or better? Especially if it has gotten worse, that's something that needs to be reported immediately. And any change in color or amount of their sputum. They always have secretions kind of floating around in there, but change in color or amount can indicate an infection, right? If it was a white color and now it's green, that may indicate we've got an infection going on. Dyspnea, the shortness of breath. If their lungs are healthy and functioning at the moment they're doing the treatments, they should not have shortness of breath. But as those lungs start to shut down, or maybe they have an infection going on, they're going to have increased respiratory symptoms. That could include dyspnea, cyanosis, abnormal lung sounds. Their lung sounds will go all over the place. It may be clear 1 minute, it may be wheezing, crackles, rhonchi the next, just depending on those secretions. If the lungs are healthy and not having any issues, SpO2 should be normal. Again, if they have an infection or those lungs are starting to shut down and they're heading into more of that COPD-like picture, then they will have decreased oxygenation. And because of this chronic low O2 level, we'll see things like clubbed fingers and toes, or spoon nails. If you remember talking about those with adults, this is not an infant that's going to get this. It's not an infant that's like born with that. The clubbed fingers and toes will basically develop from chronic low oxygen levels. So any kiddo that has respiratory or cardiac issues and has just chronically low oxygen levels, we usually will see that. Typically around 2 to 3 years of age, we'll start to see those symptoms present. In your GI tract, the thick secretions block the ducts throughout all of the GI tract, so pancreas, the bile. It causes problems everywhere throughout the body. So things to think about, pancreatic fibrosis, because of that blockage, will lead to diabetes mellitus and enough damage in the pancreas that they will have diabetes. And it's treated similar to a type 1 diabetic, where they end up needing insulin. They get blood sugar checks before meals. They're going to have impaired digestion and absorption of fat, which can lead to things like steatorrhea, and also in impaired digestion and absorption of protein because of those, those small intestines being blocked by the thick, sticky mucus. Impaired salivation is also impacted, and obstruction of the bile duct as well, which kind of goes along with the fat absorption that we were talking about. GI assessment. So your GI assessment includes things like your height, weight, and growth chart. We're going to see, are they age appropriate or not? And most of these kids are going to have some level of failure to thrive. They're going to be usually skinny extremities, the big protuberant bellies with that barrel chest, kind of like the quadricore malnutrition that we talked about a couple weeks ago, because of that problem with protein absorption for these kiddos. Things like skin turgor may be impacted. Think about that fluid electrolyte imbalance from sodium, from sweating out all their sodium. Their mucous membranes may be a little bit drier. They may not be as moist, and that can impair things like salivation, which impairs digestion and chewing food. Their diet history includes that failure to thrive, and they can have increased weight loss despite having a good appetite. These kids can eat and eat and eat and still not gain weight because they're going to have problems with absorption. Activity intolerance, and that's related to a couple things. That's related to digestion and food and energy, but that's also related to respiratory. And then the malabsorption of their fat and their protein can lead to things like steatorrhea, which are the kind of bulky, foul-smelling stools because of that high fat content that can happen in them. They get the big bellies with the thin extremities, like I talked about. In the newborn, one of the earliest warning signs of this in the newborn, right, the baby that's just born, could be a meconium ileus, where they don't have that first bowel movement that they're supposed to have. That's, within the first 24, 48 hours for baby. And then labs for electrolytes and blood sugar levels may be altered for this kiddo. So presentation, a couple other things that we see with kids that have CF. I talked about a couple of these things a little bit with the delayed puberty and sterility in boys. Parents describe that their kids taste salty as well because they're sweating out that sodium chloride. So when parents go to kiss their kid, they give them a little kiss on the forehead, like a baby, they give them a little kiss on the forehead, they taste salty. And that was especially one of the things that parents used to note before we had this kind of commonplace genetic testing that kind of led to a diagnosis of getting CF testing. Was parents there's respiratory symptoms, but my kid tastes salty. Why does my kid taste salty? It's not like they're licking their kiddo, they're kissing them and they taste salty. Dehydration can happen secondary to those electrolyte imbalances. Things like hyponatremia, hypoalbuminemia are also problems that we see for kiddos. So our goals of treatment for a patient with CF, we want to prevent and minimize pulmonary complications. And that means doing treatments and respiratory health. We want to make sure that they're getting adequate nutrition for growth. And then we're helping them adapt to chronic illness, because this is a lifelong disorder that will eventually cause death for these patients. So respiratory management. So we have CPT vest and postural drainage vests. And I've got the picture here with this little kid with the vest on. And these vests basically give them this vibration. They shake them and they loosen up all the secretions. And then they'll do postural drainage where they kind of bend over and they do coughing and they get all those secretions out after they've been loosened up. Sometimes they do breathing treatments at the same time, like you're seeing here, that help loosen those up. It can be inhaled medications like a bronchodilator. It could be an inhaled antibiotic. It could just be inhaled saline to help loosen up the secretions, to help loosen them up and get them out. These vest treatments are usually up to 4 times a day. They are exhausting for families. That means every morning before school, they do 2 during the school day, and then they're going to do 1 at bedtime. It's really hard to keep up with them sometimes. But the kids that do really well with the CPT treatment and are maintaining and doing what they should will have a better quality of life and longer life expectancy. I have a link on the slide here for a newer type of vest that you could click on the link for that one and watch it outside as well, so I don't get in trouble for copyright on my video. But the Afflo vest one is a portable one. It's actually battery operated, and so they wear it throughout the day, and it is a game changer for families. Oh my gosh, these kids can wear this and do their treatments in the car. They can do their treatments at home. They can do their treatments in school. They can travel with it. Like, it is such an improvement on quality of life versus these ones like this little kid's wearing here that have to be plugged in. There's a big box that they're attached to. They are just so cumbersome. They're super loud too. These other vests are just amazing. They are expensive. So I mentioned socioeconomics. That is something that really significantly impacts families' ability to buy one of those. It's not covered by insurance right now because there's other forms that are available, like these less expensive ones that, they're not as good for quality of life, but they get the job done. And there are some programs out there that help pay for them. So really, I'm hoping that things like these portable vests make it much more accessible for a larger chunk of patients so that they can get treatment as well, and improve quality of life. Other things that we do, I talked about bronchodilator medications, especially if they're doing a treatment. Forced expiration activities. In that video that I mentioned with One Republic, he's doing them in that video where he's doing this like breathing exercises. That forced expiration helps with airway movement. Any sign of a pulmonary infection, any change in a cough, any change in sputum, any fever needs to be reported immediately for a patient so that they can get treatment, so it doesn't get worse. And that sometimes is home IV antibiotics. Sometimes these kids have PICC lines that they will get home treatments for. Sometimes they need to be admitted for that. They get aerosolized antibiotics as well sometimes. They are high risk for pneumothorax. Remember those thick, sticky mucus in there can cause those airways to collapse down. Steroid use is also very common, especially if they're having an exacerbation. They're usually put on steroids. Non-steroidal anti-inflammatories may also be taken on a regular basis. And then eventually this can lead to transplantation. Because this is a disorder that will eventually lead to fibrosis of the lungs will eventually stop working, just like a patient with COPD. And this happens at a much younger age than our elderly patients with COPD. This can be a teenager or 20-year-old. This used to be very, very young on, but the life expectancy for CF is about 36 years of age now, so it's improved pretty significantly. When I first started working as a nurse, it was still late teens, so it's improved very drastically just in the last 16 years or so. And one of the reasons that improvement has kind of happened is because of transplantation. So patients can get a bilateral lung transplant. Unfortunately, it doesn't eliminate the genetic disorder, so these patients will still eventually cause fibrosis of the new lungs, but it does give them improved quality of life and an added life expectancy. So it does add on about 5 to 10 years of increased life expectancy for patients after transplant. Your GI management. So we were going to replace those pancreatic enzymes, and that needs to happen before all meals and snacks. And it depends on the age of the patient. Infants, we usually are doing these little droplets to replace the enzymes. Older kids, it's usually taking a pill. They're kind of like giant vitamin horse pills. Older kids may be taking 5 of them with a meal. So it depends on their size and their age on how many of those they're taking, but it has to be with every meal and every snack. They need extra fat soluble vitamins daily. They need a high protein, high calorie diet. They can eat whatever they want. They can go down to the cafeteria and get 2 cheeseburgers and 2 milkshakes and 2 plates of fries, and still not gain weight. Our minimum goal that we're aiming for is 150% of what their daily recommended amount based on their age is going to be. Don't feed them before their respiratory treatment. If they're doing that vest treatment and you just feed this kid this giant meal, right, and then you put this vest on that's like blah, 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 and is shaking them, they're going to puke on you. So it's management in the hospital includes planning out the day. And most of the time, if you're in a larger facility, it's going to be respiratory therapy that's doing the respiratory treatment. So make sure that you've kind of coordinated it with them so that you're not feeding at the same time that treatment is about to happen. For infants, they need special formula. We can't just give them regular formula. They need increased calories and nutrition. So the 2 forms of special formula that we use for younger kids would be something like Progestamil or Nutramigen. They are at risk for intestinal obstructions, so things like a bowel perforation and an obstruction, looking for signs and symptoms such as abdominal swelling, increased abdominal pain, and distension of the abdomen. They are also at a little bit higher risk of rectal prolapses, and then they also usually need salt supplementation, especially in the summertime when they're out and they're sweating, or they're playing a sport and they're sweating. So our prognosis for cystic fibrosis, the median age of survival is about 36.8, and really has not changed since 2011. We had a lot of things that changed up and before 2011, but it's kind of stayed stable since about that time period. The 5-year survival rate post-transplantation is still about 60%, so about half of patients that get a bilateral lung transplant survive. And they will be on immunosuppressive medications for the rest of their life if they get a lung transplant. And things that really improve quality of life for these patients, really following that strict nutritious plan, being able to get all of their calories in, getting their protein in, preventing and treating infections, doing their best treatments every single day without fail. They keep up with those treatments. They have a better quality of life long term, as well as a longer life expectancy. This used to be considered a pediatric disorder. It's no longer considered a pediatric disorder. We used to keep patients that had CF in the peds hospital. It was always a little bit strange for me when I had a patient that was admitted for CF and they were like 30 years old and married and had kids of their own. And I'm like, this is not the norm for pediatric nurses to deal with a patient in that lifespan, that life period. But we transition these patients out of pediatric medicine in most cases nowadays. So there are cystic fibrosis adult treatment plans now. So typically children's, if they hit 18, we help them transition to adult care with CF. And that can have some challenges with it as well, but it's definitely something where they're not staying in a pediatric treatment facility for their life expectancy. New research, things that have improved life expectancy. There's gene therapy, and gene therapy is a little bit different than something like a bone marrow transplant. Basically, gene therapy is looking at that specific gene that's damaged or altered, duplicated, whatever it is, and correcting it. And then, taking it out, correcting it, and then injecting the patient with the corrected form of the gene. The body starts replicating it and replaces their damaged gene with this healthy gene, and we stop having the disorder. They're actually kind of close to developing this. Close in relative terms. That could still mean a decade from now, but it's definitely really cool technology that they're coming out with. The bilateral lung transplants has also really improved life expectancy and quality of life for patients. And then there's newer medications that have come out in the last couple of years. iVector is one that just came out maybe 5 years or so ago. It's also crazy expensive, like $300,000 a year, like the cost of a house. Insurances will pay for it in some cases. There are grants for it and those kind of things for families to get paid for. And unfortunately, it only treats one specific form of cystic fibrosis, so it doesn't treat the other types of cystic fibrosis that patients may have. So if they have that one specific type, they are able to get it and get it paid for with insurance, then they have a much greater improved quality of life, less infections, less complications, but it's not a cure-all either. Family support is important with a kiddo that has chronic health. Coping with the emotional needs of the family and friends and siblings long-term is an important part of management for this one. They require these treatments multiple times a day. Imagine the 2-year-old that doesn't like to listen to the adult, throws those temper tantrums that we talked about last week, and just has to do these treatments 4 times a day, or they get held down to do their treatments 4 times a day. Parents get tired of doing that. Kids get tired of doing the treatments. So family support with that, we really don't give leeway of like, if they need to do the best treatments 4 times a day, they have to do the best treatments 4 times a day. There shouldn't be like oh, well, you need a break, let's take the day off. No. Thinking about other ways to help families cope. Frequent hospitalizations, especially if they're not following their treatment plan and they're not doing those treatments at home, they get hospitalized. We talked about behavior and kids that are sick and parents that want to do everything possible for their kid while they're in the hospital. Well, this is a population that does not have any cognitive deficiencies. This is a physical disorder. You need these kids to have an understanding that they have a chronic health disorder, but that doesn't mean that they can get away with anything. And that sometimes is the case for parents. They're like, oh, well, they're sick. They're going to die by the time they get to be 30 anyway. Let's just let them do whatever. They still need to go through the normal process of being a kid, and limit setting and rules and figuring out who they are as kids is still really important for them, because especially if they survive, we want them to be functioning adults. The genetic transmission of the disease is something that we want to make sure that we talk with families about, that they understand that if they have another child that has that potentially could have cystic fibrosis, right, that 1 in 4 chance, if they're going to get pregnant again. That includes, females that may get pregnant again, or males that maybe get pregnant in non-traditional, that can collect sperm in non-traditional ways. There's a genetic risk of passing this disorder down. Exposure to pathogens, we want to report immediately. Fever, cough, changing sputum, and treat immediately, right? Usually that's things like antibiotics, increased respiratory treatments. We're going to treat immediately for these kids. The other thing to think about with exposure to pathogens is, the 6 feet rule that's come out with COVID is not a new rule. It's always been the case that we say with patients that have cystic fibrosis is they need to stay at least 6 feet away from each other. There was a movie called 5 Feet, 5 Feet Apart, 5 Feet Apart, I think is the name of it. 5 feet away, 5 feet apart. That's about kids that have cystic fibrosis that kind of get in this relationship with each other. And it's based on a book. I can't remember the name of the lady's name. Basically, this is true, right? If we have 2 kids that have cystic fibrosis that are more susceptible to respiratory illnesses than we see in a non-cystic fibrosis population, these kids can kill each other, like literally. This one has this rare fungal infection, this one has this rare bacterial infection that they're dealing with. They get together, their lungs are so susceptible that they share those germs, and one patient could kill the other patient by passing on that disorder. So we don't encourage teens and kids and family members with cystic fibrosis to intermingle with each other. Now, if all the kids are living in the same household, they're usually all colonized with the same thing. So something like them sharing a room in the hospital, because it happens, is fine because they're all sharing the household space at home. But when we have 2 kids from 2 different families that have different pathogens that they're being exposed to, we don't want to share rooms with them. There was one night at Children's, and our pulmonary floor, at this time, we used to have a research department and a pulmonary floor up on the 9th floor. So the one half of the 9th floor used to be just CF patients and the research patients. So it was considered like the clean floor because the CF patients are susceptible to illness. The research patients were usually healthy, not always, but healthy patients that were there just for like a research study for labs or something like that, right? So I was up there as charge nurse up there one night, and there was a tornado warning. There was an actual tornado outside of the hospital, and if you've ever driven past it, it's giant glass walls, right? So we get this warning alert, so we have to evacuate the rooms, and it's like 10 o'clock at night, so I had to go around the rooms, wake people up, and get kids into the central part of the hospital, away from those windows, right? And so I've got all of these cystic fibrosis patients. I couldn't just put them into the nurse's station in the middle. I had to separate them. So it was literally me like 2 kids in one room, and I'm like, you put your mask on, and don't move corridors. And I had people like scattered throughout the halls. I had somebody in the bedroom. Like I just had people scattered everywhere. So they were more than that 6 feet apart. Families were not super happy with me, and they had to stay out in the hallways or rooms or wherever it was for over an hour until we got the all clear. But they cannot share germs with each other. It can be really harmful to their overall health. Cystic fibrosis. This is a nice little overview. So those of you that like a quick, friendly version of this is one way to remember this. And then respiratory failure. So this is defined as the inability of the respiratory system to maintain adequate oxygenation. These are kids that are breathing rapidly, have respiratory distress, and will go into respiratory failure. They're just not able to keep up with that oxygen demand. So if our patient goes into respiratory failure, we need to address it. And there's lots of things that cause respiratory failure in kids. It could be obstructive lung disorders. I've got here things like an aspiration, like meconium that's just thick and blocks those airways, or a tumor potentially. Restrictive lung diseases like cystic fibrosis, or a near drowning where there's just fluid building up in there. ARDS, right, would kind of fall into that category. Insufficient gas exchange can also lead to this. So that could be something like a CNS infection like meningitis or drug overdose. An embolism can lead to complications that lead to respiratory failure. There's lots of things out there that can lead to this. So manifestations, remember I mentioned earlier at the very beginning of this lecture that one of the first signs of respiratory distress is tachypnea. Kids will increase that respiratory rate. They'll breathe faster. And then we're going to see that heart rate follow, right? So tachypnea, tachycardia. They're restless, they're having trouble getting oxygen in, so they're going to be a little bit restless and irritable. And then diaphoresis, they're sweaty, right? Their body's sweaty from trying to maintain that oxygen perfusion. So treatment for these little guys, whatever age it is, right? CPR suctioning, depending on what the underlying cause is. If they've got flu, and it's more lower airway inflammation, suctioning may not be the best treatment for this. If it's bronchiolitis and they've just got all these secretions clearing it, then suction is going to be a much better choice. We need to maintain ventilation. We need to correct that hypoxia, hypercapnia imbalance that may be going on there. So that could be something like intubation and further mechanical ventilation for these patients. And I've got the other examples that we talked about, something like nitric oxide or the high frequency oscillator or ECMO to help maintain that ventilation for a patient. Remember, there's different sizes of bag valve mass. There's an infant, there's a peds, and there's adult that you'll see generally. There's some other, a little bit other sizes, but generally what you'll find in a healthcare institution or at the bedside in your like safety kit at the bedside is going to be infant, peds, and adult. Now, if all you have is an adult face mask and you have an infant, that's all you have, right? You're going to use what you have. You better not be squeezing this entire bag, because that basically is controlling the tidal volume of how much breath you're giving your patient. This is a tiny amount. This is about 2 liters in the adult size. The infant one is about 500, so significant difference in tidal volume, right? So the face mask is also going to be dependent on the size. There's, size 1, size 2, size 3. So finding the right size. Hopefully you have a kit at the bedside that has the different sizes in it, and especially in peds, we keep one of every size. That should be part of your safety checks at the bedside, that you've got those safety equipments there if you need it. And then cardioresuscitation, CPR. Pediatric cardiac arrest frequently represents the terminal event following respiratory failure or progressive shock. Now, what does that basically mean? Cardiac arrest is more likely to come from respiratory arrest in a pediatric patient. We do not see things like heart attacks as easily with our pediatric patients. It's just not something that kids are like, they're just going to have a heart attack or a cardiac event, and that leads to CPR. If you have a patient that goes into cardiac arrest, think respiratory first. That's one of the first things that usually triggers cardiac arrest with a peds patient. Address the respiratory first, unless you know that they have a cardiac disorder. This kid has a VSD, a ventricle septal defect, and that could be what triggered the cardiac arrest. And so your management is going to be a little bit differently than it would be for a flu patient. But know that most sudden cardiac events in peds patients are triggered by respiratory events. All right, a couple post-test questions here. So we've got a 7-month-old taken to the pediatrician's office with a low-grade fever, nasal congestion, and a mild cough. What should the nursing care management of this child include? So are we maintaining strict bed rest? Are we avoiding contact with family members? Are we installing nasal nose drops and bulb suctioning? Or keeping the head of the bed flat? So this one we're going to be doing our, suction. Suction would be the right answer on this one. All right, there are several kids in the ER waiting area who all have asthma. The nurse has 1 room left in the ER. 1 room left. It's a busy night. Based on the following information, which child should be seen first? The 5-year-old who is speaking in complete sentences, is pink in color, is wheezing bilaterally, and has an O2 sat of 93. The 9-year-old who is quiet, pale in color, has diminished breath sounds and an O2 sat of 92. The 12-month-old who has a mild cry, is pale in color, has diminished breath sounds and an O2 sat of 93. Or the 16-year-old who is speaking in short sentences, is wheezing, is sitting upright, and has an O2 saturation of 93. So hopefully reading through those, you would agree they're all patients that need to be seen, but who is the most urgent? Who is the most urgent? 3 is your most urgent. Think about why. Why would 3 be your most urgent patient? 2 and 3 are pretty similar, right? We've got a 9-year-old and a 12-month-old. They're both pale in color. They're both quiet or mild cry. They both have diminished lung sounds. Both of their oxygen levels are about the same. 3 is more correct because that age, right? The younger the patient, the more susceptible they are to respiratory illness and have decreased ability to compensate. The 9-year-old has a little bit more ability to compensate than the 12-month-old. So that's the main reason why 3 is your right answer versus 2. And let's see, a 6-month-old admitted to the hospital with reactive airways disease, or RAD. The nurse is assessing the child. Which of the following physical findings should be of most concern? The baby is tachypnic, or tachypnea. The baby has tachypnea. The baby has mild retractions. The baby has wheezing, or the baby has grunting. So think back to the very beginning of the lecture, what I talk about with this one. Grunting is your most severe finding on this baby, the most severe finding. And then a 2-month-old seen in the pediatrician's office for his 2-month well checkup. The nurse is assessing the patient and reports to the physician the child is exhibiting early signs of respiratory distress. Which of the following would be an early sign of distress? Infant is breathing slowly. The infant has tachypnea. The infant has tachycardia. The infant has bradycardia. So what is an early sign of distress? I just talked about it. I talked about it at the very beginning. So hopefully you remember that tachypnea, that respiratory rate is going to be the first thing that's going to be an early sign. Then we see the tachycardia. Then we're going to see bradypnea, bradycardia. And we've got a 2-year-old brought to the ER with a high fever, dysphagia, drooling, rapid pulse, and tachypnea. What should the nurse's first action be? Prepare for an immediate IV, prepare for an immediate respiratory treatment, place the child on a stretcher for a thorough exam, or allow the child to sit on the patient's lap while awaiting treatment. What should your first action be? This is not what your most important action is. This is your first action. You've got a 2-year-old. So I want them to sit with the parent, right? I want to keep them calm. Then I'm going to do other things, right? I'm going to be doing my assessment. I might be doing a respiratory treatment. I, may be doing an immediate respiratory treatment on this patient, especially something like a racemic epi. But I need to assess my kiddo first, and I need to keep them calm. So your first goal, keep them calm. Then go from there. Think about your ABCs from there, okay? If this question had said, what is your most important action or your highest priority action, then it would be your immediate respiratory treatment. But because it's saying first, keep them calm, keep them with mom.